Hello, a very good afternoon to all the delegates for SATCON 2024 IMA Medical Association Satara branch. So please be with us. Very soon we'll be starting with our CME and anesthesia workshop. So all those delegates who have joined, please switch off your videos and please make a note that your audio is also switched off. It's a request. We'll be joining you soon. Be online. Thank you. Good afternoon, ladies and gentlemen, and thank you to be patient with us. A warm and virtual welcome to SATCON 2024, a distinguished gathering of medical professionals. It's an honor to stand before this esteemed assembly as we embark on 3 days of immersive learning, collaboration, and engagement. Over the next few days, SATCON 2024 will serve as a virtual nexus for the exchange of knowledge and ideas, encompassing a spectrum of enriching experiences. From the precision of anesthesia workshop to the dynamic dialogues within our panel discussions and the insightful lectures are crafted to cater to the diverse facets of the modern healthcare. Our collective commitment to excellence, learning, and the advancement of healthcare unites us in this virtual space. While the format may be different, the spirit of collaboration remains unwavering. Take advantage of the opportunities to connect, share, and build professional relationships that transcend borders. Thank you, dear delegates, for being an integral part of SATCON 2024. Together, let us make these 3 days a testament to the resilience, adaptability, and strength of medical community. Welcome to SATCON 2024. Now, I would like to call upon Dr. Madhuri Limaye Madam, who is past president of Indian Society of Anesthesiology Satara, to start our anesthesia workshop today. Thank you.
Thank you, Dr. Rajashri, and good afternoon, everybody. I feel an immense pleasure to welcome you all to this workshop. This is a social activity of ISA Satara branch about the anesthesia awareness and the basic life support training consistently for the last 15 years. We have trained thousands of people and saved many lives. This social work also has given us identity at the state and the national level and lots of prizes. We are also participating in the IMA conference every year, and I am thankful to the IMA organizers for giving us the opportunity. I wish all the success to SATCON 2024. Thank you. And for the basic life support training, I invite our colleague Dr. Maruti Pawar. Dr. Maruti Pawar, he has done MBBS from JMC Mirrors and MD Anesthesia from Nagpur. He is an associate professor, MPSC selected in 2014. He is the ex-secretary of ISA Kolhapur branch and organizing member of PGCon Kolhapur in 2014 and organizing secretary PGCon 2017. He has many publications, 3 international, 2 national, and paper at the YFCA World Congress of Anesthesia in 2020, Prague. Publication awaited are spinal in eclampsia, 200 cases, mucormycosis, 200 cases, and USG-guided hernial block, 75 cases. His areas of interest are the trauma anesthesia, neonatal anesthesia, obstetric anesthesia, and BLS and CPCR training. I welcome Dr. Maruti Pawar.
Good afternoon, everybody. Thank you, Limaye Madam, for the kind introduction. Myself, Maruti Pawar, Associate Professor, Anesthesia, recently transferred to Satara. So I'll be talking about basic life support. Before starting, I would like to thank the organizers, Satara KMA, Medical Association, and ISA Satara. So it's a bridging or the theme of the SATCON. We are bridging some gap between the two cities in relationships, enhancing relationships. As I am from Kolhapur, and regarding ISA, there may be more collaboration between Satara and Kolhapur. So thank you once again for the opportunity. So let's go with basic life support. The word cardiac is added because I will be specifically speaking about the cardiac support. As you can see, the yellow color of my slide, because while you're traveling on the roads, you see the traffic lights, yellow, green and red. So this is a transition of life which is in the yellow color, and it will change. If it is successful, it will change to green, and if not, it will turn to red, that is death of the life. The terminology introduced life support are basic life support, BLS, basic cardiac life support, BCLS, which is my topic, CPR, cardiopulmonary resuscitation, CPCR, cardiopulmonary cerebral resuscitation, COLS. This is a new entity introduced by our AHA, our decision committee, compressions only life support, because they are focusing only on compressions. This is used for the training of lay persons or bystanders for the better outcome. PALS, that is pediatric advanced life support, and ATLS, advanced trauma life support. By definition, basic cardiac life support is a sequence of actions or care taken during the first few minutes of emergency of victim survival. BCLS defines these actions which may save life if done promptly and sequentially, because 70% of survival reported in patients if they are evidenced and bystanders given the CPCR. What is the chain of survival? This is the early recognition and call for help to prevent the cardiac arrest. Second, early CPR. Third is early defibrillation. Fourth is post resuscitation care to restore the quality of life. Early CPR to buy the time before the team arrives and the patient is handed over to the expertise. Before going for that, ensure the safety of the patient and safety of yourself. The scene is happen on the road, by the side, or drowning patient, or shock, burn. So you have to be at a safe place or ship the patient at the safe place and then only go for your action. While considering the trauma patients, you should keep in mind that patient should not be mobilized because there are possible injury to the spinal cord. What they are safety? Electric current, poisoning, snake bite, or accident. Recently corona, be careful. First is assess. What to assess? This is a checking a pulse. Ask the person, are you okay? So here we start the sequence of, once you by the side of your victim, ask the person, are you okay? Tap and shout, are you okay? Whatever kaka mama in your slang language. If the client responds, leave the client and call for help. Return quickly as possible to reassess the condition of the person. Now check the pulse, carotid. Where to check? That is by the side of the trachea. Okay. If the patient is not responding, then activate the emergency medical services, that is call for help. Now in India, it is a 108 ambulance number. You can directly call. And what to tell on call is place, number of victims and type of accident or event. And also ask them to bring AED. Then the sequence is ABCD, but it is changed since 2010 AHA guidelines to CAB, that is chest compressions, airway maintenance, and breathing. And D for the defibrillation. We will come one by one. Next, please. Now for the chest compression, what is the position of the rescuer? This is by the side of the patient, kneeling if the patient is on the ground, or if on the bed, then by the side of the bed. Okay, this is the position. Placement of the hands. Where to compress? So the chest, the point of compression is at the level of nipple, lower third of the sternum in the center. So that is the point where you place your heel of compressing hands. Now what is the position of the hands? Hand should be, the dominant hand should be on the chest first and second hand over the first. The hands are tightly fisted, locked, and elbow joint should be straight and locked. There should not be a bowing of the hands, so that we can directly transfer our weight of our body to the victim's chest. If the victim is less than 1 year, the position is the same but with the 2 fingers. The characters of the good compression is push hard and push fast. Push hard. Hard means at the rate of 100 to 120 per minute. Count in your mind. Compression depth, the force should be at least 2 inches depth or 1/3 of the diameter of the anterior posterior of the chest. Release compressions in between to recoil and fill the chambers with the blood. If the ventilation is possible to give, then 30 to 2 inhalation. One precaution is do not bounce your hands up and down the victim's chest, and never use the palm. Use your heel of the hand. Otherwise, you may break the ribs of the victims. If there are 2 resuscitators available, then go for 30 to 30 compressions and 2 breathing. Advanced airway and 2 resuscitators, then go for intubation and continuous CPCR. Now the airway. When the victim is unconscious, so this is how to open the airway. This is a triple maneuver, a jaw thrust maneuver, in where the neck injury or spine injury suspected. You cannot do the head tilt and chin lift right now. This is done. So it is not possible in case of cervical spine injury. At that time, you just do the jaw thrust, that is pushing the lower jaw downwards. Okay. This is a chin lift. Okay. And head tilt. In pediatric patients, same. So once the airway is opened, you clear the airway by handkerchief or see for any foodstuffs or any particles. If there is, then clear it. Otherwise, you open the airway so that the oxygenation is possible. Now, when breathing is there, you check for look, listen and feel. Look, chest if rising, listen with ear if the movement of air, and feel the respiration. If it is absent, that means you have to provide the respiration. Then once you open the airway, give 2 rescue breaths. If the victim is neonate or pediatric patient, first you give the breathing. 2 rescue breaths will buy the time of oxygenation and you go for directly compressions. Then how to give this thing breathing? That is, bystander or outside the hospital, there is nothing to or instrumentation means to give the breaths. At that time, you can give mouth to mouth or mouth to nose breaths. That is, like in picture, you open the airway, clench the nose and take a deep breath and give a sealing to mouth or nose of the victim and give full expansion of the chest or what is possible. That is, you can deliver at least 4 to 500 ml of volume. Two rescue breaths will help to maintain some oxygenation, and you can go for the compression. These are some devices, that is face mask or simple mask, or this mask you can give directly to mouth to mask by sealing around the face. These are some methods: intubation by securing the airway, like intubation by means of ET tubes and this thing. It is possible in in-house, in-hospital scenario. Other devices like ambu bag, where you can give the breaths, like holding a mask around the patient's nose and mouth and providing some positive pressure ventilations. But this is again possible in hospital scenarios. Otherwise, outdoor or out hospital, you have to go for mouth to mouth breathing. The odd situations like pregnancy or cervical spine injuries, we will see in later lectures. Special session is on them. This is something cough CPR, but its effectiveness is under evaluation or not tested. That is, forceful continuous coughing can provide some cerebral perfusion like that. If there is no response for the BCLS, then what to do? There are some reasons. Find out what is maybe the cause. The first most suspicion is that there must be some time lapsed between the cardiac arrest and your arrival. So you have to be within a survival time, that is within 3 minutes, then only the patient is going to respond, or revival time, that is 7 minutes. After that time, it is mostly impossible to revive the patients. Second, you suspect the 5T and 5H, that is toxins, tamponade, tension pneumothorax, thrombosis, and hypovolemia, hypoxia, hypothermia, acidosis. Like this conditions needs treatment. When to stop BCLS? When to stop? Once the patient is showing some signs of ROC, that is recovery of the circulations, or breathing spontaneously, became awake. Second is, if the qualified help is arrived and take over. Third, if the rescuer becomes exhausted. You cannot continue for the half an hour, 15 minutes of effective CPR. That is the limiting factor. So BCLS at the last includes defibrillation. That will be covered in next session. This is the AD machine, and this another session on the specially on the defibrillation. So it will be covered in details. So this is how the AED pads are applied, how the AED acts, that is conduction of the current flow. This is the scenario when to give a shock, that is all clear. And lastly, this is the recovery position. This is left lateral or either right lateral, so that patients maintains airway, breathing, and the circulation is enhanced. And you have to transfer these patients immediately to the higher centers, which are the medical management care units are prepared beforehand. So this is a summary about the BLS. Only thing is push hard and push fast. Sequence is the same. There are some automated CPR machines. Now you can see the videos over this YouTube. That is the compressions over the chest, and the CPR is given by a machine. These are some references for your, and do one thing and do it better than anyone else. Thank you. Now let me introduce our next speaker, Secretary of ISA Satara. Dr. Jyoti Jadhav, Madam. Dr. Jute has done MBBS and diploma in anesthesia, consultant anesthesiologist since 2009 in Civil Hospital Satara. She's the secretary of Satara, as I told. Her special interest in high-risk obstetrics and ICU management. She worked in COVID pandemic and given anesthesia to many COVID positive patients. It's a terrifying job. Congratulations, madam, and welcome to the dais. Thank you.
Thank you, Dr. Pawar, for excellent presentation. And on behalf of IMA, we would like to felicitate Dr. Pawar. Thank you.
Good afternoon, friends, and thank you, SATCON, for giving us ISA Satara this opportunity to conduct this workshop today on anesthesia. Today's my topic is advanced cardiac life support or the comprehensive cardiopulmonary life support. Dr. Maruti Pawar sir has completed basic life support. There are 3 types of these resuscitations are there. Compression only life support, that is a cardiopulmonary resuscitation by layperson outside the hospital. It includes chest compression. Basic pulmonary life support for cardiopulmonary resuscitation by trained paramedics and medics outside the hospital. It includes chest compression, breathing, and early defibrillation. And third is the comprehensive cardiopulmonary life support or the ACLS, that is by the trained paramedics and medics inside the hospital. It includes mainly chest compression, breathing, early defibrillation, advanced airways, use of drugs, and defibrillation, and treating the reversible causes of this cardiac arrest. This is the chain for ACLS: early recognition and management of pre-arrest condition, early recognition and activation of code blue in the hospital, early high quality CPR, early defibrillation, and early comprehensive life support and post-resuscitation care. This is the in-hospital cardiac arrest, out-hospital cardiac arrest chain. What is ACLS? ACLS is basic life support plus equipment for securing airway, IVSS, drugs, cardiac monitoring, differential diagnosis, and treating the reversible causes, and the post-resuscitation care. Advanced cardiac life support includes airway, breathing, circulation, and the differential diagnosis. In airway, sir has discussed the use of head tilt, chin lift, different oropharyngeal airways, nasopharyngeal airway, endotracheal airway, laryngeal mask airway, eye gels, laryngeal mask airways, eye gels, combi tubes, and the cricothyrotomy set. Endotracheal tube. This is the definitive method to secure a compromised airway. It requires laryngoscopy. It prevents aspiration and initiates mechanical ventilation. Laryngeal mask airway or the eye gel, they are high rate of success in inexperienced hands. There is no need of laryngoscope. It is inserted into the lower oropharynx and we can use it for short periods. Okay. Next is the emergency cricothyroid emergency airway. With 12 or 14 gauge cannula, we can do cricothyrotomy in the cricothyroid membrane. It is an emergency airway procedure. These are the different video laryngoscopes, CMAC video, videoscope, glide scope, and these are the supraglottic airway devices: LMA, classic AML, LMA, supreme LMA, eye gels, or again. What is breathing? With advanced airway, we give one breath for 6 to 8 seconds. That is 8 to 10 breaths per minute. It is not to be synchronized with compression. In COLS and BLS, we give 30 compressions and 2 breathings. But when we introduce the airway in ACLS, there is no need to synchronize with compression. We give 8 to 10 breaths per minute. How we will do confirmation of this device placement? That is chest expansion, 5-point auscultation, moisture over the inner side of the tube, end tidal CO2, that is the ET CO2. Then circulation, IV or intraosseous assess. Attach ECG leads, identify and monitor arrhythmias, give IV fluids. Circulation, how we will maintain? Peripheral venous assess, that is cephalic or external jugular vein. Intraosseous, endotracheal routes are there. Use of drugs, that's atropine. It enhances the automaticity and conduction of both sinoatrial and atrioventricular node. The role of atropine is in slow pulseless electrical activity. Dose is 1 milligrams. IV repeat every 3 minutes. Adrenaline, we know, vasopressin, and lidocaine, amiodarone, and soda bicar. What are the different causes of this cardiac arrest, or what are the reversible causes? There is a mnemonic, hit the target. There are 5H, 5Ts. That is hypovolemia, hypoxia, hydrogen, that is acidosis, hypo or hyperkalemia, hypothermia. And 5Ts are toxins or tablets, cardiac tamponade, tension pneumothorax, coronary thrombosis, pulmonary thrombosis or embolism. These are the guidelines that are developed year by year. In 2005, it was up to 2005, it was ABC, that is airway, breathing and circulation. People used to give, clear the airway, giving breathing, but they were reluctant to give breathing because of the infection or the hygiene problems. So chest compression, they could not proceed. So in 2010, it is converted into CAB, that is chest compression, airway and breathing. At least they will give chest compression. In 2015, it is CAB, and we should give 100 to 120 compressions per minute, and the compression breathing ratio is 30:2. That is push hard, push fast. The upper limit of depth 6 centimeter is added. Look, listen, feel, that is removed. Next is the attach the monitor. You will find these arrhythmias. What is the approach to arrhythmias? Start CPR, give oxygen, attach monitor, and use of defibrillator. What are the shockable rhythms for defibrillator? That is a ventricular fibrillation, pulseless ventricular tachycardia. We can give a defibrillate. Then asystole and pulseless electrical activity. These are the non-shockable rhythms. We use epinephrine as soon as possible. These are the bradyarrhythmias. We after observing ECG, we can identify the rate, rhythm. This is first degree, second degree Mobis type 1, Mobis type 2, third degree heart blocks. In first degree, there is prolongation of the PR interval. In second degree Mobis 1, there is prolongation of PR interval, progressive, and there is misbeat. In Mobis 2, there is prolonged PR interval. In third degree, there is no correlation between the P wave and the QRS complex. Identify if it is a bradyarrhythmia or a tachyarrhythmia, or it is a stable rhythm or an unstable rhythm. There are Hasia signs for academic purpose. These Hasia signs means H for hypotension, altered mental status, signs and symptoms of shock, that is diaphoresis, patient will tell घबराहट हो रही है, ischemic chest pain, acute pulmonary edema, that is breathlessness features. From this we can say, if the Hasia signs are present, we can say this is an unstable rhythm. If this bradyarrhythmia is there, that is heart rate is less than 50 per minute, then identify, maintain the patient's airway, give oxygen if hypoxemic, cardiac monitoring is done, 12-lead ECG, IVSS is done, 12-lead ECG if available, don't delay in therapy, consider possible hypoxic and toxicological cases. The treatment is atropine, that is first dose is 1 milligram bolus, repeat every 3 to 5 minutes, maximum is 3 milligrams, then give dopamine, then again 5 to 20 micrograms per kg per minute, then epinephrine 2 to 10 micrograms per kg per minute. If it is not responding, then consult a cardiologist or intensivist for transvenous pacing or the further management. Tachyarrhythmias. Identify this tachycardia, if it is a stable or unstable. Again, the Hasia signs. Identify the QRS complex, it is normal or wide. Identify tachycardia, if it is a regular or irregular. If the persistent tachyarrhythmias occurs, then find out the causes. That is again Hasia signs, hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. If these Hasia signs are present, yes, then synchronize the cardioversion. Consider sedation. If regular narrow complex, consider adenosine. If refractory, then need to increase the energy level for next cardioversion. If these Hasia signs are not present, but the wide QRS is there more than 0.12 seconds, yes, then adenosine, regular and monomorphic. If antiarrhythmic drugs, expert consultation. If the QRS complex is not more than 0.12 seconds, then vagal maneuvers, adenosine if regular, beta blockers or calcium channel blockers, consider an expert consultation. These are the tachyarrhythmias, narrow complex, wide complex, regular, irregular. What are these narrow regular arrhythmias are? Sinus tachycardia, supraventricular tachycardia, paroxysmal supraventricular tachycardia, atrial fibrillation. We can do cardioversion with 50 joules. There are wide regular monomorphic ventricular tachycardias with 100 joules we can revert. Narrow irregular atrial fibrillation, multifocal atrial tachycardia, 100 to 150 joules. When there is wide irregular, that is the shockable rhythm, ventricular tachycardia, ventricular fibrillation, torsade pointis, go for defibrillation. This is the automated external, there are two types of defibrillator, that is automated external defibrillator and the manual defibrillator. This is the diagram of automated external defibrillator. They are available at railway stations, airports. So this defibrillator having rhythm detection capacity and the ability to advise the operator to deliver a shock using hands-free defibrillator pads. Untrained or briefly trained laypersons, fully automated, it is fully automated or semi-automated. This is the position of pads in AED. What is defibrillation? It is a process in which an electronic device sends an electric shock to the heart to stop an extremely rapid, irregular heartbeat and restore the normal heart rhythm. These are the indications for defibrillation. We hesitate to do defibrillator, but according to norms now we are keeping defibrillator in our OTs. We should freely use this defibrillator, use monitor, identify these rhythms. What are the indications of the defibrillators? Pulseless ventricular tachycardia, ventricular fibrillation. What are the three features? It has a power source, capacitor, two electrodes. These are the position of electrodes, sternoapical, anteroposterior, or the biaxillary positions. There are two types of defibrillator, monophasic versus biphasic waveforms. This monophasic defibrillator delivers a charge in only one direction. It is high energy shock. Previously, old defibrillators are there. They give 360 to 400 joules. These newly are the biphasic defibrillators, delivers a charge in one direction for half of the shock and in the electrically opposite direction for second half. That is 120 to 200 joules. This is the current delivery in one direction by monophasic defibrillator. This is the current delivery in two directions. What is the procedure? Dr. Chaitali, we will confirm the cardiac arrest, check for the signs of life. CPR should be ongoing. Turn the defibrillator on. Stop chest compression, confirm ventricular tachycardia from the ECG. Squeeze generous amount of jelly on the defibrillator paddles. The designated person select the appropriate energy on the defibrillator, that is 150 to 200 joules for biphasic defibrillators and 150 to 360 joules for monophasic defibrillator. Then press charge button to charge the capacitor. While the defibrillator is charging, warn all rescuers other than the individual performing the chest compression to stand clear and remove any oxygen delivery device as appropriate. Synchronize. Once the defibrillator is charged, tell the rescuer doing the chest compressions to stand clear. When clear, discharge the current by pressing the both paddles of the discharge button simultaneously and give shock. Examine the patient's ECG to see whether defibrillation has altered the patient condition and restore the normal rhythm. Continue CPR for 2 minutes.
Very important to synchronize delivering the shock just to prevent RNT phenomena. Very important. There is one other which is called as synchronize. So before delivering the shock, you have to synchronize the. So many. Hello. So many good defibrillators are having synchronization. So it is sometimes it is inbuilt. No? So you don't need to synchronize, but it has to be there, yeah? Just to prevent RNT phenomenon. Yes. Yes. Okay. Okay.
Some defibrillators, advanced defibrillators, they are synchronized. So to synchronize defibrillator synchronize, we can use these newer defibrillators, so that if we are not ECG trained, so we can use these synchronized defibrillators. Perform the 3 counter shocks in rapid succession. If the patient still has no pulse after 3 initial defibrillations, resume CPR, give supplemental oxygen. Then begin administering epinephrine and switch on to non-shockable algorithm. Is stopping resuscitation, responsibility of the most experienced doctor present and should involve the whole team. If there is very poor prognosis, that is asystole or pulseless electrical activity, if the cause is undiagnosed, there is no response to BLS or adrenaline, successful resuscitation becomes unlikely after 12 shocks and it is rare. After 15 to 20 minutes of attempted resuscitation. When not to start CPR, a valid do not resuscitate order, obvious sign of death present, that is rigor mortis, injuries incompatible with life. These are the advanced gadgets for chest compression available. Atopus, Lucas. This is the advanced CPR, ECMO CPR, extracorporeal membrane oxygenation CPRs available in hospitals. What is a good team dynamics? It is said that for COLS only one person is required. For BLS at least 2 persons, one will give chest compression, one will give breathing. And for this ACLS, more than 3 persons, an ideal 6 persons are required. One will be a team leader, one will take care of this airway, one will give compressions, one will take the responsibility of IV, and one will defibrillate, and one will record all these events. This team leader should know the strength and weakness of his colleagues. He should allot roles. There should be clear instructions for all these people working in this ACLS. So let us all be COLS, BCLS and ACLL providers. Let's be masters of resuscitation. Thank you.
I request Dr. Hemlata Kadam Madam to felicitate our speaker, Dr. Jyoti Madam, and also coordinator, Dr. Jathar Madam.
Thank you, Jyoti, for very practical and useful presentation. And thank you, Chaitali, for good demonstration. So the take-home message is, please don't hesitate to ventilate the patient. Even if you can't intubate, We have new gadgets such as IMA, iGel. So you can ventilate the patient and don't hesitate to use the defibrillator also. Thank you, Jyoti, and thank you, Chaitali.
The next speaker is Dr. Madhuri Lime, madam, our senior, past. She is a past president of ISS Satara City branch. She is practicing anesthesiologist since last 35 years. Active member of Satara Anesthesia Association since last 35 years. Secretary ISS Satara 2008 to 2014. She is a MMC observer. She is IMA Ladies Wing Advisory Council member. Conducting anesthesia awareness and CPR training for last 15 years. Privileged to volunteer as anesthesiologist at surgical camps at Rotary, Leelavati Hospital, Mumbai, Hemal Kasa, Lok Biradari project by Dr. Prakash and Mandatai Amte. Shodgram project by Dr. Abhay and Rani Bang. I welcome Dr. Madhuri Lime madam for her next speech.
Thank you, Dr. Jyoti, for kind introduction. So, Dr. Jyoti and Dr. Pawar have very informative lecture about the compression only life support, basic life support and advanced life support. So let us see in which situation we have to use it. So some emergency management in critical situations, fainting, syncope, vasovagal attack, road traffic accidents, drowning, choking and the electric shock. So just now we saw the importance of time. Time is life. I want to just stress it that every 1 minute decreases the chances of survival by 10%. So at the end of 10 minutes, there are hardly any chances of brain survival. So the time and life are the co-teachers. Life teaches us the use of time and time teaches us the value of life. Just I want to stress about the IRC guidelines. The considering Indian geographical situations, transport facility and the medical facility, our Indian Society of Anesthesiologists has founded the Indian Resuscitation Council. And now we are not following American guidelines, we are following our Indian guidelines. So we feel very proud to be. So just now we saw co-links. I am not going in details. The importance of early recognition, early diagnosis, early activation, early chest compression and the early transfer. Now coming to the fainting attacks. What are the signs? There are dizziness, yawning, sweating, dry mouth, restlessness, blurred vision and the pallor. The causes being pain, anxiety, some frightening or horrified incidents. The most important is while giving intramuscular and the intravenous injections, local infiltrations and the spinal anesthesia. Because whenever a patient faints, it is mistaken as the anaphylaxis and the treatment of fainting and the anaphylaxis is totally different. Treatment being for the fainting and the syncopal attacks, allow the patient to lie down, elevate the legs. If patient is conscious, then only give water or liquids. Observe the patient and if patient is unconscious, give cardiopulmonary resuscitation. So please do not make person sit or stand with a support, and please do not give water or liquids to the unconscious person. So the main points are no oral to the unconscious patient, and of course no CPR to the conscious patient. Just you can imagine giving CPR to the conscious patient. So this is the first aid about the fainting. Just now we saw all the details. Now coming to the road traffic accidents. Of course this data is few years before, but very sad part is India tops in the road deaths. One accident every minute and one death due to accident every 4 minutes. So accident death will be the 5th major cause of death in India, and death in the RTA is due to brain injury or the bleeding, external or internal. The causes being poor enforcement of the helmet, no seat belt wearing, especially in the back seat, high speed of vehicle, consumption of alcohol, deadly roads, and inadequate ambulance facility and pre-hospital care. So the very sad part is 80% are alive at the accident site. Here we can consider the importance of our cardiopulmonary resuscitation first aid. 70% are young and all causes are preventable. This is a scenario at the road traffic accident. So what happens at the site? All present at the site are intending to help, but nobody knows what to do and how to do. No organization is seen, there is no plan of management, there is no teamwork, everybody is doing as per personal wish and knowledge, and everybody is in a hurry. Especially nowadays, everybody is busy in taking the photographs and the videos. This help will be more dangerous. And about the legal issues, who want to help in the road traffic accident, the Supreme Court has announced that any person who meets the road accident can be taken to the nearby hospital immediately. Hospital must not ask for police report to admit him. It's doctor's duty to do first aid. Police can be informed later. Now the first step in the road traffic accident, just now we saw, look around the scene to ensure no imminent danger to threat. If the victim is in the danger, there are few methods to move the victim shown in the picture. How to move the victim. Important part is about the spine stabilization. When do you suspect cervical spine injury? Whenever there is a head trauma, broken collarbone or polytrauma. So do not shake or tap on the face to elicit the response, as this may cause movement at the neck level and which could harm victim with a cervical spine injury. So this is how the cervical spine stabilization is done. Do not move the casualty from the position unless the patient is in the danger or becoming unconscious. Now coming to the next scenario, drowning. The drowning is a death caused by fluid inhaled into the respiratory tract and the reflex cardiac arrest in cold water or spasm of the glottis, which results in a decrease of gas exchange in the lungs. Obviously, in drowning, there is a air hunger. Patient is usually panicked. So patient takes reflex inspiratory efforts leading to aspiration of water and laryngospasm, giving rise to asphyxia and hypoxemia and acidosis. So there is a gasp reflex which gives rise to aspiration and drowning, and also it gives rise to the hyperventilation, decreased carbon dioxide, respiratory alkalosis, cerebral vasoconstriction, and decreased mental functioning, and patient possible convulsions, patient becomes unconscious. So if laryngospasm is maintained, there is respiratory arrest, then cardiac arrest, and it is dry drowning. If there is relaxation of the airway, water enters the lung, surfactant washout, ventilation perfusion mismatch, and it is wet drowning. So initially within 1 minute, patient loses consciousness due to hypoxia, and after 10 minutes, the heart may fibrillate. So the treatment of drowning is for the defibrillating heart, defibrillation, for the respiration, of course, artificial ventilation, and if respiration and cardiac activity stop, give cardiopulmonary resuscitation. So if the drowning patient is conscious and no aspiration, just observe the patient. If there is a aspiration, give oxygen and transfer to the hospital. Avoid hypothermia. Aspiration can cause late complications such as neurogenic, pulmonary edema, pneumonia, DIC, hemolysis, hepatic and renal failure, and bowel necrosis, and all the complications of hypothermia. If patient is found unconscious, give CPR. If possible, give 100% oxygen and immediate transfer to the hospital. So in drowning, we are supposed to give 2 rescue breaths. So how to give 2 rescue breaths? Either mouth to mouth, mouth to mask, mouth to nose. So pinch the nose, take normal breath, place lips over the mouth, seal the lips, blow until the chest rises. For about 1 second, allow chest to fall and repeat. So this is the picture about how to give the mouth-to-mouth respiration. If mask is available, it is safer to give the mouth-to-mask ventilation. And put the patient in the recovery position, that is the lateral position, and if patient is unconscious, of course, we have to give the CPR. So this is the chart about mouth to mouth and mouth to nose respiration. 2 initial breaths, wait for end of expiration, 10 breaths per minute, and each breath should take about 1.5 to 2 seconds. Control ventilation, check chest movements, and check the air return. Now the next scenario, very important, choking. This is the typical signs symptoms of choking. Choking is a life-threatening situation and happens when the casualty's airway suddenly gets blocked, so they cannot breathe normally. The common causes of choking: foreign body in the child and food in the adult. What are the signs and symptoms? Grasping of the throat, anxious, distress, difficulty in speaking and breathing, persistent cough, pale gray or blue skin developing, and patient becoming unconscious. The typical picture of engorged neck veins due to increased intrathoracic pressure in choking. So it is a foreign body airway obstruction. If it is mild, there is a good air exchange. So ask the patient to cough forcefully. If it is severe, there is no or poor gas exchange, ineffective cough, high pitched noise while inhaling, respiratory difficulty, and cyanosis. Unable to speak with universal choking signs, just we saw. There is a cough, breathlessness, retrosternal discomfort, cyanosis, tachycardia, tachypnea, wheeze, crackles in the chest, pink frothy sputum, and the reduced consciousness. So what are the manuals for the relief of choking? Encourage patient to cough and breathe and monitor. Call ambulance if problem continues. If it is severe, perform Heimlich maneuver. And in infants, do not use abdominal thrust. In pregnant and obese people, we can use chest thrust instead of abdominal thrust. So the choking first aid is give 5 back blows between the person's shoulder blade, that is scapula, with the heel of your hand. And what is the Heimlich maneuver? Stand or kneel behind the victim with arms around the victim's waist. Make a fist, place above the navel and below the breastbone in the midline. So the position will be above the umbilicus and between the zyphisternum. Grasp the fist with other hand and press into victim's abdomen with quick upward thrust as if we are lifting the patient. Repeat till the object is expelled or patient is unresponsive. Though this is how the Heimlich maneuver is done. Is the pictorial picture. This is the whenever there is nobody to help, we can do the self Heimlich maneuver. That is, put our fist in between the zyphisternum and the umbilicus and give upward and backward thrust, and we can take help of a edge of a chair. So for the choking, first 5 blows in between the scapula and then the Heimlich maneuver, abdominal thrust. Now about the infant. If the infant is responsive, kneel or sit with infant in your lap. Hold the infant prone or forearm on the forearm resting on the lap with head lower than the chest. Deliver 5 back slap forcefully, sufficient to dislodge the foreign body between infant's shoulder blades. Using heel of our hand, turn the infant on its back with support of the forearm and give 5 chest thrusts at the rate of 1 per second. If the infant is unresponsive, place on the flat surface, open airway, remove object if visible only. Do not perform blind sweeps. CPR with one extra step, that each time you open the airway, check for the object, 5 cycles of CPR and activate emergency services. So this is how 5 back slaps and 5 chest compressions. So immediate hospital management in the choking will be assess and manage the airway, breathing and circulation, 100% oxygen, pulse oximetry, watch for the false reading caused by peripheral shutdown and acidosis, and all the investigations such as chest x-ray, blood gases, serology, observation and management of the hypothermia. Now coming to the electrical shock. It is defined as the physical contact with energized wire or electrical device are the most common cause of electrical shock. So what is the meaning? When there is a sudden discharge of current through the body, it is said to have undergone the electric shock. So it can be defined as the passing of electrical energy through the portion of the body causing shock. It may cause wound or it may not leave any visible sign on the body. In both cases, electrical current passing through the body cause damage internally, cardiac arrest or another injuries. In some cases, so what is the difference between electrical injuries, low voltage and high voltage? In low voltage, is less than 600 volt, more common because it is of greater access. Half of all the injuries and deaths are due to the low voltage. Burns tends to be minor. Half of the low voltage deaths have no burns. Low voltage AC can cause cardiac arrest, usually ventricular fibrillation. Other arrhythmias are rare with low voltage. Coming to the high voltage, skin burns are severe, violent skeletal muscle contraction, so it throws the victim, fracture, dislocations, posterior shoulder often missed. Clinical picture resembles the crush injury because of the muscle trauma. High voltage causes a systolic cardiac arrest and dysarrhythmias. So this is the pathophysiology of the electrical injuries. Increased resistance produces increased heat. So the tissue resistance, now the blood gives more resistance, muscle, skin, tendon, fat and the bone gives highest resistance. So burns are across the flexor creases. AC is 3 times worse than the DC because DC causes the tetany. So in the AC current, it is the exit is equal to entrance. So the patient is held in the position, and in the DC current, exit is more than the entrance. So patient is thrown. So the clinical effects about the skin neurovascular exam may underestimate the injury. Skin injury is variable. This is the comparison between low voltage, high voltage and the lightning injuries. So do not approach the victim, of course, directly, but before ensure the following: that check for the danger for yourself and any other bystander. And then remove patient from the electrical source without touching directly with the resistance any instrument. Use any non-conductor material. So this is the first aid for the electrical injuries. And of course, whenever patient is unconscious, we are supposed to give CPR. So thank you very much for the patience listening. And all of our ISA member feels that it is the purity of the heart that matters, not the external appearance, because helping hands are always better than praying lips. Thank you very much.
I request Dr. Hemlata madam to felicitate our speaker, Dr. Limay madam.
I'd like to invite Dr. Aruna Rassal, our colleague. Dr. Aruna has done MBBS and DA in 2000. She has done fellowship in HIV medicine from CMC Vellore in 2009. She has also done fellowship in pain and palliative care in 2013, fellowship in diabetics in 2019. She is a consultant anesthesiology and HIV and the tuberculosis consultant in Indian Red Cross Society, Bel Air Hospital, Pasgani since 2001. She is a consultant in Nodal DR TB Center in Bel Air Hospital, Pasgani. So I invite Dr. Aruna Rassal.
Good afternoon all. Before starting my presentation, I would like to thank IMA Satara City Branch for giving me this opportunity. I also thank ISA Satara City Branch office bearers for giving me this opportunity. As we have seen previously, we need to give different drugs during ACLS in emergency rooms. Every one of us, even in the OPD basis, in emergency rooms, in primary, secondary and tertiary care units, we handle emergencies and we have to move fast to save our patients. During this, we don't know the HIV, hepatitis or any other illness status of the patient. As we just want to save our patients, we are always in a hurry. So to prevent the exposure of the blood and the body fluids of the patient, the universal precautions are same. So with the permission of the office bearers of Satara City Branch, I modified my topic to universal precautions instead of only HIV. So this objectives of the sessions will be to understand the need for system of post-exposure prophylaxis, to enumerate the illnesses transmissible occupationally, evaluate a healthcare worker sustaining an injury, prescribe the appropriate PEP, discuss the follow-up procedures after PEP, and discuss the prevention of occupational exposures. So as we know that there is a large coverage of antiretroviral therapy throughout the world as well as more in India, we are, and patients with HIV, the lifespan is increasing. So these patients are coming to us with non-communicable diseases like diabetes, hypertension, ISDs during accidents in our emergency rooms, and there are increasing chances of accidental exposure to blood and body fluids. So what type of exposures we will get? A percutaneous injury, that is needle stick or cut with a sharp instrument, contact with mucous membranes of eyes or mouth, contact with non-intact skin, or contact with intact skin when the duration of the contact is prolonged with blood or other potentially infectious body fluids. So who are at risk? Everyone who is attending the emergency room is at risk, including the nursing staff, students, emergency care providers, labor room personnel, surgeons, operation theater staff, lab technicians, interns, medical students, dentists, physicians, health facility cleaning staff, mortuary staff, and clinical waste handlers. So what are the fluids and which are more infectious? So exposure to the body fluids considered at risk are blood, semen, vaginal secretions, CSF, synovial, pleural, peritoneal, pericardial, amniotic fluids, and other body fluids which contains visible blood. But tears, sweat, urine, feces, saliva, sputum, vomitus, which is not with the blood, are not infectious. So how needle stick injuries occur? So the commonest needles which are at risk of having needle stick injuries are the hypodermic needles. Hypodermic needles are the needles which we use commonly for giving injections, either IM or IV. So the activities associated with needle stick injuries are handling and transferring the specimens, improperly disposed shafts, disposal related causes, collusion with the healthcare workers or the shafts, during cleaning, recapping of the needles, handling or and passing the devices during and after the use, IV line related causes, manipulating the needle in the patients, and many more. So what are the main diseases which are at risk for transmission? Mainly hepatitis B, hepatitis C, and HIV. So others, what we have seen then that when there is a mouth-to-mouth respiration, then there could be some transmission of diseases like tuberculosis or cryptococcus, and sometimes through blood like malaria or syphilis. But the chances of this transmission is less. So more commonly is a hepatitis B, hepatitis C, and HIV. So the risk of transmission depends upon the type of exposure. If there is a percutaneous injury, the chances of for HIV it is 0.3%. For hepatitis B, it is 9 to 30%. For hepatitis C, it is 1 to 1.8%. If it is a mucous membrane exposure, the transmission is 0.09%. So how does the needle stick injuries occur? The commonest is recapping of the needles, disposing of needles, administering the injections, drawing out the blood, and handling thrush and dirty atoms. So recapping is the most common cause. 25 to 30% of the injuries will occur while recapping the needle. We all have a habit of taking one syringe with open needle in one hand and cap in another hand. Extremely dangerous to hold like this and start recapping the needles. Improper disposal, forgetfulness, it may be unintentional, but whenever there is an emergency, we always forget to recap the cover the needles or put the needles properly. We always forget the syringes with open needles bedside or in the trays. Inconvenient disposal system, when there is a lack of puncture proof disposal system and containers specially for disposing of the needles. Lack of motivation, especially in the smaller units or smaller centers where they handle emergencies, there may not be a proper protocol for universal precautions. This can be unintentional, but still we are not paying much attention to follow the guidelines in the hospital settings during emergencies. While administrating the injections and drawing out the blood, especially in the polytrauma care units where patients who are with multiple fractures are in a severe pain and they must be moving a lot. So this time there could be more chances of needle stick injuries. Then the patients with convulsions, again there are more chances of injuries. And again in pediatric patients, because the pediatric patients are more moving and not stable. Handling the thrush and dirty atoms, when the needles are disposed of in garbage bags instead of properly disposing them into puncture proof disposing containers. So the people who are handling these garbages or the cleaning people are having accidental injuries due to this. So how to manage this? Don't be panic, terminate your procedure, remove the gloves, encourage the bleeding, wash with running water and soap. I would like to tell that whenever there is a needle prick, we always squeeze our finger. So never squeeze your finger, because once you release your pressure, there will be a negative pressure inside the finger and the blood will get sucked in. So never squeeze the finger, just allow to bleed the puncture site. Use the disinfectant or saline. Notify your supervisor immediately. Seek the medical help and always document it. So how to manage the exposed part? For the skin, if the skin is pierced by a needle stick or a sharp instrument, immediately wash the wound and the surrounding skin with water and soap and rinse it. Do not scrub it. Do not use antiseptic or skin washes. Do not use bleach, chlorine, alcohol or betadine. Do not put cut finger as a reflex action in the mouth. For the eyes, irrigate the exposed eye immediately with water or normal saline. Sit in the chair, tilt the head back, ask the colleague to gently pour the water or normal saline over the eyes. If you are wearing contact lenses, never remove the contact lenses because it will protect the eye. Once the eyes are cleaned, then remove the contact lenses. Do not use soap or disinfectant on the eyes. For the mouth, spit out immediately. Rinse the mouth thoroughly using the water or saline and spit again. Repeat this procedure several times. Do not use soap or disinfectant in the mouth. Consult the consult to the physician immediately. So if we have a needle stick injuries, we need a post-exposure prophylaxis. So post-exposure prophylaxis is any preventive medical treatment started after the exposure to a pathogen in order to prevent the infection from occurring. So after the exposure, we will send a blood sample of both the source, that is patient, and the exposed healthcare personnel or a doctor for testing. For testing for hepatitis B, we will check hepatitis surface antigen in the source. We will check hepatitis C virus, that is antibodies, and viral load as well as ALT levels. And for HIV, we will check antibodies to HIV. And nowadays, we can also check viral loads of the patients because many patients are on antiretroviral therapy. So once we are exposed, how to manage? For healthcare for hepatitis B, if the healthcare provider is vaccinated, we have to check for the antibody levels. If the antibody levels are more than 10 international units per ml, then there is no need of post-exposure prophylaxis. But if the levels are less than 10 international units per ml, then definitely we have to check the status of a patient. If the patient is HBsAg negative, then only booster dose of hepatitis B is required. If the source is unknown, then again the booster dose. But if the patient is HBsAg positive, then we have to take a booster dose along or complete series of vaccination along with hepatitis B immunoglobulins. If the healthcare provider is not at all vaccinated, then immediately we have to give him vaccine within 7 days along with immunoglobulins 0.06 ml per kg. For hepatitis C, as we all know, there is no vaccine for hepatitis C. We have to monitor the exposed healthcare personnel. We have to monitor for antibody to hepatitis C, the viral load, that is RNA levels in the serum, the liver enzymes, and we have to repeat all these tests every 2 to 8 weeks. Then for HIV, we know nowadays all the patients are on almost all the patients are on antiretroviral therapy. And previously the guidelines were depending upon the exposure of the needle stick injuries. We used to give either 2 drugs or 3 drug combination. And the therapy was tenofovir, lamivudine and lopinavir, ritonavir combination. But because with NACO's guidelines, all the patients who are diagnosed HIV positive are on tenofovir, lamivudine and dolutegravir. This is a combination from different classes of the drugs. So we have to give same antiretroviral therapy as a post-exposure prophylaxis. This comes in a combination of single tablet, and we have to give once in a day for 28 days. And that has to be started within 2 hours. There is no use of giving or prescribing antiretroviral therapy after 72 hours. And one more thing, we have to always explain our patients to take antiretroviral therapy at the fixed time, because the MAC value of the drugs will remain in the drug at particular time, and once the dose MAC value is reduced, there is again the chances of resistance to the virus increases. So we have to give exactly, if we start at 2 o'clock 2 p.m., then next day also 2 p.m. is the time for taking antiretroviral therapy, even for post-exposure prophylaxis. So this table will summarize what to give after exposure due to needle stick injuries or sharp injuries. Every patient who is having needle prick injuries, and we have to counsel them, and we have to give them information that what is PEP, what are the risks and benefits of PEP. It is always clear that PEP is not mandatory. Details of window period and baseline test, especially for HIV virus, the window period is of 6 weeks. So the drugs, and we have to also give the information what are the drugs we are giving to them, their safety, their efficacy, and the issues related to the drugs during pregnancy and breastfeeding. Similarly, patients who are exposed to HIV positive patients, the healthcare personnel who are exposed to the HIV positive personnel, then we have to counsel them for safe sex practices, that is a barrier method, and till their baseline test and 3 months HIV tests are negative. Psychological support is must, especially for HIV. Everyone who is exposed to needle stick injuries by the HIV positive patients will be very anxious. So exposed person should be informed that the chances of having HIV infection due to needle stick injuries is only 0.3%. And nowadays almost all the patients are on antiretroviral therapy. Their viral loads are undetectable. So the chances of transmission due to needle stick injuries are very, very rare, and this will relieve their anxiety. Some may require further specialized psychological support. Documentation of the record is essential. We can give them leave for 2 weeks initially, and after that, depending upon their mental stress, side effects, and requirement. Clinical monitoring is must, because there are a lot of side effects of the drugs. We have to monitor for acute seroconversion illness within 3 to 6 weeks after the exposure. If they are suspected, we have to refer them to ART centers. Need to counsel them for avoiding blood donation, breastfeeding, and pregnancy. Those we have to also counsel for the safe sex practices, and adherence and adverse reaction counseling to the exposed person. So with all this, there is always prevention is better than cure, because universal precautions, especially in small setups, we don't follow the guidelines, or we don't have proper protocols or proper training to our staff. So universal precautions are must. Always we have to use the gloves, personal protective equipments, decontamination, hand washing, and waste disposal. So whenever we are doing any procedure, always use protective gear. Every sample, either it is blood or it is body fluid, always consider it as infectious. Follow the universal precautions, safe handling of the sharps as well as needles, use of needle destroyers. We have little doubt about this use of needle destroyers, because even if we cut the needle, there is some part which can prick or which can have a needle stick injuries to the healthcare personnel. So our intention is good to save our patients. So we are always in a hurry, but still it takes very less time to wear double gloves. So always make a habit to wear gloves whenever we are handling any emergency in any situation. Always use mask, cap, and eyewear. Nowadays we are in a habit of using all these because of COVID era. So never underestimate the importance of use of cap and mask. A simple plastic gown underneath the apron or any linen will prevent from soaking with the blood as well as other body fluids and exposure to the harmful microbes. Wearing footwear. This is a part where we always forget to wear the footwears. Remember, many of us have cracks on our feet. So always wear proper footwears which can cover the entire sole, which can protect us from the body blood or body fluids. Especially the trauma care centers where there is a lot of blood on the floor, and that's why they should always have a proper system to wear the footwears. Sharp injuries prevention, correct disposal of appropriate container, avoid the recapping, avoid removing the needle, discard the syringes as a single unit, avoid overfilling sharp container. So even if you we want to recap the needle, make a habit of recapping the needle or recapping the needle with single hand. Disposal of the needles and sharp, always all used needles and sharps should be disposed in thick wall puncture resistant containers. Bending, recapping, reshaping should be prohibited. Do not recap the needles to avoid the injuries. All the used disposable syringes and needles or sharps should be discarded into a bleach solution or 1% hypochlorite solution. Hand hygiene, we all know that hand hygiene is always must after any procedure or before any procedure for at least 15 to 20 seconds. And other prevention guidelines will be, this is especially for the workers. They may have injuries when disposing of the needles. They can have, whenever they are picking up the containers which are completely filled, there are chances of or the sharps may, they may have the injuries because the sharps are filling out of the container. So, and the wide mouth containers, always the needles will come out, and that's why we have to give them a proper disposable system. Employee training is must. As I told earlier, even if it is a smaller settings, we should always have a proper training to our all staff if we are handling emergencies, and that is full barrier technique. Double mask, double gloves, correct sterilization protocols, and disinfection on the surface with either 1% hypochlorite solution or bleach solution. Thank you.
I request Dr. Yavatkar sir to felicitate our speaker, Rasala madam. I request Dr. Sanjay Patil sir to chair next session. I welcome Dr. Sanjay Patil sir on the stage. Patil madam to introduce Dr. Avinash Bhosle sir.
Thank you for giving me the opportunity of introducing our dynamic leader, Dr. Avinash Patil. He has gone. Slide, please. Dr. Avinash Patil, he is MD Anesthesiology of Avinash Bhosle, sorry. MD Anesthesiology. He is a freelancer, private practitioner since last 26 years. Founder, secretary and past president, ISA Satara City Branch. He is past honorary secretary, vice president, GC member of ISA Maharashtra State. He is vice president and past secretary of SAMS, past secretary, president, state and national representative of IMA state. It has gone. Previous slide, please. President Appreciation Award for IMA State for Best President of IMA. Individual awards also, he has got many individual awards for awareness of at national and state level. Record of 14 awards at state and national level in presidentship of ISA. He has arranged many conferences, CME, workshops, health camp, blood donation camps, awareness, and CPR programs at Secretary of ISA and IMA Satara. He was a dynamic secretary recently of State Maharashtra, and now he is Vice President of All India level. Many guest lectures at state and district level in ISA and IMA conference and CMEs. He is member of District COVID Force and District Legal Services, and he is a regular marathon runner, 42 kilometers and 21 kilometers, more than 35. I request Dr. Avinash Bhosle to deliver his lecture.
Good afternoon, everybody. Thank you, Shashi Madam, for this my kind introduction. First, I thank personally and on behalf of ISA Satara City Branch to the organizers of IMA Satara City and the organizers of the SATCON 24. We have already discussed ACLS, BLS, in previous three, 4 lectures, and CPR in various situations. But this CPR in pregnancy is a special situation. Why it is special? Because it is concerned with the 2 lives, that is mother and fetus. So it is a complex and it required the multidisciplinary and multi-speciality and a critical decision making for during this CPR in pregnancy. So in this lecture we will discuss following these points: introduction, causes of cardiac arrest, anatomical and physiological changes in pregnancy, management of the unstable pregnant patient, modification for resuscitation in pregnancy, how to perform perimortem cesarean section, that is PMCD, treatment of cause leading to cardiac arrest, post arrest care, and last assessment of the fetus and newborn. Before going to the CPR, we should know some terminology. What is maternal collapse? It is defined as an acute event involving the cardiorespiratory and cerebrovascular system resulting in reduced or absent conscious level at any stage in pregnancy and up to 6 weeks after delivery. What is the maternal mortality? Is defined as the death of a woman during pregnancy and up to 42 days after delivery or termination of the pregnancy, provided that the cause of death is related to or aggravated by the pregnancy or its management. So it is what is the difference? What is the incidence? It's even this collapse incidence is very rare, but it is important because again it is concerned to the fetus, mother and fetus. There are 2 lives, so it is important. Range is 1:20,000 to 1:50,000 pregnancies. It is for the maternal collapse. Maternal mortality rate of 14 days per 1,000 maternities. Globally, 800 days occur daily. Out of 5,29,000 maternal deaths globally, almost 1,36,000 days, that is 25% of deaths from India each occur in India each year. But I am happy to share you that the maternal mortality ratio is declined since 1990. In 1990, it was more than 500. In 2070, it comes to 103, and now it is less than 100. It is 97 per 1 lakh live births. So maternal mortality ratio in India is reducing, and I am happy to say that this rate is only 33% in Maharashtra. So the ratio is declining. What are the causes of this? All deaths can be now even preventable. 30% of the deaths can be preventable because all these patients are young. What is the other causes? Several studies have reported that most of the physician and obstetrician or gynecologists that may respond to perform CPR in pregnancy lack the necessary knowledge and skill to manage the maternal resuscitation. So this rate is maternal deaths are more. Another cause that is from the patient's end, because increasingly women who have risk factor for heart disease are becoming pregnant. Now they are coming in pregnancy with older age. They may have diabetes, high blood pressure, obesity, high cholesterol, chronic problems such as kidney diseases, seizure disorder, lung diseases. So this maternal death or this maternal collapse is increasing. You can, what are the causes of cardiac arrest? We will see the causes before going to CPR, because we should treat the cause also. When you are treating, you are giving CPR, you have to treat the cause also. So causes of cardiac arrest, it can be divided into unknown incidents, abrupt, unpredictable, or gradual or expected, or it can be simply classified as a cardiac or non-cardiac. But you can easily remember the causes of cardiac arrest, like A, B, C, D, E, F, G, H, and T. A, B, C, D, anesthetic drug, accident; B, bleeding; C, cardiac disease; D, drugs; embolism; F, fever; GIT symptom; and H, you know the 5H and 5H, T, like hypoxia, hypothermia, hypovolemia, hypertension, hypoglycemia, and T is the cardiac tamponade, toxin, trauma, and thromboembolism. Before going to the CPR, we should know the anatomical and physiological changes during pregnancy. In short, I will tell cardiovascular changes: maternal blood volume, uteroplacental arterial blood pressure increases. You know, the in pregnancy there is a hyperdynamic circulation, systemic vascular resistance is decreased, but cardiac output increases by 30 to 45%, heart rate increases. But in supine pregnant patient, due to gravid uterine pressure, compression of IVC decreases venous return, and cardiac output is decreased by 10 to 30%. So there is a poor venous flow in the infradiaphragmatic IV site, like femoral and saphenous vein. So these two routes, infradiaphragmatic routes, are not recommended for IV assays during resuscitation. You have to take the upper extremity IV line for during resuscitation. Respiratory system, there are many changes. Tidal volume increases, there is a RVC decrease, but oxygen consumption increases because of the demand of the fetus and maternal metabolic processes. The residual functional capacity decrease, reservoir decrease, there is hypoventilation, and this causes the hypoxemia, leading to hypotension and cardiac arrest. Airway changes, there is a tremendous edema of the tongue, mucosa, supraglottic edema. There is the mucosa is fragile. Then the ribs are flared, the elevated diaphragm. The patient is there is a weight gain in the patient, and if patient is obese, the large breast. All these causes difficult intubation, difficult ventilation, and difficult to visualize the cords, and all these cause the difficult intubation, and so it is difficult to give CPR or to ventilate the pressure. The progesterone relaxes the GIT sphincter, that's why there is a chances of aspiration. Then GFR is increased, then drug metabolism is altered, protein binding changes are also alter the free fraction of the drug. So all these changes are there. Now we will see how to prevent the this cardiac arrest. So before any patient that if there is any causes hypovolemia, hypotension, we have to treat or we have to diagnose the patient. Prevention of cardiac arrest by early detection of critically ill patient is most important. Early warning score, early warning, obstetric early warning score monitoring can prevent or help to initiate timely treatment, and so it reduces the mortality. So this early warning score is based on the clinical parameters like temperature, pulse rate, respiratory rate, systemic blood pressure, uterine volume, mode of birth, consciousness level. And I think it should also include the, which is not included in this score, is SpO2. That is saturation. So SpO2, oxygen saturation is also important. It should be included. So all these parameters can predict severe maternal outcome. Women having abnormal parameters, either lower or higher than the normal, then that is normally 0, and that above or lower than that value, there are likely to be a bad or maternal outcome if these parameters are not. So this is very important, and you can chart out this like this table. Then how to manage this critically ill patient? All these critically ill patients should be managed, diagnosed, monitored, or shifted to SDU, that is or in the ICU. The patient should be placed in full left lateral decubitus position to relieve the aorta cable compression, administration of 100% oxygen by mask. Then intravenous access should be established above the diaphragm. Precipitating factor should be investigated and diagnosed. Treat the cause, that is, if this is hypovolemic, give fluid. If there is a bleeding, give blood. So coming to the CPR, I think this definition is already you have learned. Cardiopulmonary resuscitation is series of steps used to establish artificial ventilation and circulation in the patient who is not breathing and has no pulse. So what are the modification to the resuscitation in pregnancy than the non-pregnant patient? Many CPR resuscitation parameters are the same. Standard adult resuscitation guidelines of BCLS and ACLS all are same, with the addition of left uterine displacement, that is LUD. These all are applicable. Compression rate, depth, hand placement, backboard placement, minimal interruption during compression, all are the same. So you can have call, or you can face this in different scenario. For the pregnant patient, you have to give CPR out of hospital and in the hospital. In out of hospital, you may be a bystander, or you are maybe a first witness. That is, you are out of the hospital and nearby stand or any platform or anywhere, and or you are called as a emergency medical service doctor. So in out of hospital, these two scenarios will be there. Next scenario will be in hospital. You may require the basic life support or ACLS. The two most important intervals, please remember, the two most important intervals affecting patient survival are the collapse to first CPR interval, or collapse to the, if you have a defibrillator, collapse to first defibrillator shock interval. So time is money, you have to act promptly. This is the basic life support or compression only life support you have already discussed. For if patient is out of the hospital, compression only CPR, which involves chest compression without artificial ventilation, is recommended as the method of choice for the pregnant patient also out of the hospital. When you are called for the emergency services as a doctor, you should know the resources are available. Your staff should be well trained with the BLS, ACLS. Then you should give the chest compression, left uterine displacement, defibrillation should be available in the ambulance, and you can start it. Then you should not transport the patient if it is not stabilized. The transport should be directed toward the center that is prepared to perform PMCD, that is perimortem cesarean section, and there should be a neonatal care. So you should shift to that hospital only if it is pregnant, and the transport should be not be prolonged by more than 10 minutes. This is the algorithm for the out of hospital as an emergency service provider. We have already seen it. The cardiac arrest in pregnancy in hospital BLS algorithm should be used. First responder, nurses are often first responders in cardiopulmonary arrest, or any hospital staff member may witness or discover a patient in arrest and should be able to begin emergency care. Start basic life support. Maternal cardiac arrest emergency, that is code blue, should be activated. Emergency team consists of anesthesiologist, obstetrician, neonatologist should be there, and that obstetrician should be capable of performing the cesarean section. A defibrillator or automatic external defibrillator should be connected to the parturient. A clear airway must be established with simple airway maneuvers such as head tilt, chin lift, and jaw thrust. Ventilation with bag and mask should be started. All these procedures should be performed with the pregnant woman placed in lateral tilted position or supine, left uterine displacement. So we have seen CAB. Now it is CAB for adult pregnant. In pregnancy, it is simultaneous CABU. CABU means C for chest compression or current, that is defibrillation, A for airway, B for breathing, and U for uterine displacement. So for pregnant woman, it is CABU. So what are the factors that cause the compression of the inferior vena cava or aortocaval compression? It is, you can see the inferior cava is compressed with the weight of the baby. So weight of the fetus, number of the fetus, the weight of fluid, that is polyhydramnios, the size of the fetus, relation of the fetus to woman's anatomy, and the obesity, all will increase the aortocaval compression. So how you can manage it? There are two procedure. One is manual and one is tilt. Manual, you can give give a left uterine displacement with one hand. When you will be on the right side of the patient, you just push the uterus if it is more than 20 weeks. That is, the fundus will be at the position of umbilicus. So push upward and to the left, and you should, when you are on the right side of the patient, when you are on the left side of the patient, just pull the uterus with both of your hand upward and to to lateral. And this is the 30-degree tilt. The board is elevated. So what are the difference between manual and the tilt? The manual is preferred because it can be given anytime, anywhere, nothing is required. And when you are giving tilt to the table, there will be difficult for cardiopulmonary resuscitation, compression will be difficult for intubation, difficult for the apply the AED leads. So why it is important? Because LUD increases the ejection fraction by 8% at 20 weeks and by 27% at 32 weeks. So how the chest compression should be given in pregnancy? Use backboard during cardiopulmonary resuscitation. Air-filled mattresses should be deflated. It requires high quality chest compression. What is the high quality chest compression? That is, you push hard and fast. We say push hard and fast. Hard and fast means your chest compression should be performed at the rate of at least 100 per minute and not more than 120 per minute. Depth should be at least 5 centimeter and it should not be more than 6 centimeter. Allow the full recoil before the next compression with the minimal interruption, and a compression ventilation ratio should be 30:2. Interruption should be minimized and limited to 10 seconds only, and for specific interventions such as insertion of advanced airway, you are giving defibrillation or intubation. The position is same. The hand, you should place the heel of the one hand on the middle of the victim chest and heel of the other hand on the top of the first, so that the hands overlap and parallel. There is no specific evidence to support the changing recommendation, but some people say that when the patient is full term, that is full term pregnancy, you just give the chest compression 2 centimeter above the lower half of the sternum. That is seen, but it is said, but it is not proved. So compression are the key to better outcome of the resuscitation. How to manage the airway? For the first responder with minimal airway experience, the bag mask ventilation with 100% oxygen is the most rapid non-invasive strategy to initiate the ventilation, because most of the time we have seen there are a lot of changes, physiological and anatomical changes in the pregnancy in the airway. So it is very difficult to intubate even for the anesthesiologist. So it is better to ventilate the patient with bag and mask ventilation. The standard compression ventilation same. Most of the time people in panic hyperventilate the patient. So don't hyperventilate the patient, as it decreases the survival, because it decreases the venous return also and cardiac output. So 2-hand bag ventilation is more effective than the single hand. I will show you the how to ventilate the patient with bag and ventilation. So just leave the and you see the inflation, chest inflation. So this is the bag and mask ventilation with single hand and single person. When most of the time it is very difficult, you can ventilate with the 2 hand and ask somebody to. When it is difficult, you should ask somebody to help, and you can ventilate the patient, because it is very difficult to ventilate patient alone. You can put the mask like this. So even you can use the recent devices like this LMA, then iGel. Various types of iGels are available. So don't go for intubation, because it is if you are not experienced or you fail the intubation, go for the airway. Modern airway can be used easily. The same, how to apply the defibrillator. The same currently recommended defibrillation protocol should be used. There is no difference. The patient should be defibrillated with biphasic shock with 120 to 200 joule. Then compression should be resumed immediately after delivery of the electric shock. This is important. There should be, main is chest compression. Always remember, chest compression is more important than any other thing. So don't it should be resumed. Don't there should be less interruption for this. For in hospital setting where staff have no ECG rhythm recognition, even some doctors also, because it is very difficult, where defibrillator are used infrequently, because most of the time it is not required. This scenario comes very rare, so we are not used to it. The use of automated external defibrillator may be considered than this routine defibrillator. The automated defibrillator, it sense automatically, it gives you order and it deliver the shock. So it is very easy to read. The lateral paddle should be placed under the breast tissue, an important consideration in the pregnant patient. Remember, shock from defibrillator and the chest compression will not harm the fetus anyway. The defibrillator will not harm the fetus. Most important, the fetus will likely not survive if the mother does not receive these life-saving measures. So this is how to apply the defibrillator. And advanced life support, ask for the help, continues the basic life support. Don't resume it when you are initiating advanced life support. Continue basic life support. Rule out and treat the cause also, and decide whether cesarean section is required or we have to do the cesarean section. And always keep the patient in left lateral position. Good ventilation with bag wall mask with high flow oxygen and suctioning is must. IV fluid bolus to correct hypoventilation and hypovolemia. AED if indicated. Then endotracheal intubation done early and should be by an expert anesthesiologist or any expert person. So endotracheal intubation, while considering the endotracheal intubation, use the small ETT, that is 1 mm less than the usual. That if you are using 7 mm, use 6.5 or 6 mm intubation ETT. Then supraglottic airway placement is preferred. I have already shown you the LMA or IGEL. Attempt at airway control, fall and mask ventilation is not possible. Current guidelines for emergency invasive airway access should be followed. That everybody should know the cricothyrotomy. That is it is very easy. So you can give you can ventilate the patient. Prolonged intubation attempt should be avoided. Required pressure is not necessary. Continuous waveform capnography is must, because it is the only way to confirm that your tube is in the trachea and not in the esophagus. So capnography is must. This is the red blue code when there is an emergency. For this is the algorithm for the ACLS. What are the recent advances in CPR? Direct cardiac massage with open chest. This is if your routine conventional CPR is not effective, then direct cardiac massage with open chest can be given. Or if you have already opened the abdomen, give trans-abdominal massage. It can be possible, trans-abdominal massage can be given. Use of ultrasonography, TE and ATCOT is also important, and all these will show your show you the effectiveness of the CPR, how it is going on. So how ultrasound guided resuscitation, it will diagnose the cause. I will take 5 to 7 minutes, because after that only inauguration is there. I think the next lecture is not there. So give the ventricular required drug that is required for the arrhythmias. Then cause of arrest should be considered and treated accordingly. Then other drugs used. Please remember that combination of vasopressin, epinephrine and methylprednisolone during CPR and straight doses of hydrocortisone is in post-resuscitation shock lead to improve the survival. Epinephrine is preferred. You can give oxytocin, and if the routine CPR is not effective, you can use ECMO. How you will monitor the this is the treatment of the cause. Give oxytocin 20 units or 10 units in 9 ml of saline, so it will make a 10 ml, and give oxytocin infusion. If myocardial infarction is there, give fibrinolytic drug. If embolism, amniotic fluid embolism is there, then you should give go to the ECMO. PPH, give blood. Massive thromboembolism, thrombolysis should be done. If local anesthetic toxicity is there, give intralipid emulsion. If magnesium toxicity is there, give calcium. Give soda bicarbonate base is excess. Anticoagulant, blood products, and treatment of the cause. You should monitor these all in post-arrest care. Immediate post-arrest care, you should keep the patient in left uterine, left lateral position. Then if it should be transferred to ICU. Delivery, if cervix is fully dilated, fetal head, it at appropriate low station, immediate assisted vaginal delivery should be done. Then not every woman in cardiac arrest a candidate for PMGC. Okay. What is the decision to make the emergency cesarean delivery during CPR? Just if gestational age is less than 20 weeks, need not to be considered the cesarean section because the size of gravid uterus is unlikely to compromise the maternal cardiac output. If gestational age is 20 to 23, perform to enable successful resuscitation of the mother, not for the survival of the infant. Gestational age greater than 24 weeks, you should perform to save the life of both mother and infant. You should, there is a 4-minute rule. It was recommended that PCMD should be begin at 4 minutes and the baby should be delivered in the 5 minutes. Don't waste time in transferring the patient or giving antiseptic, taking antiseptic precaution. Only scalpel is required. But only scalpel. And during this, you should give the lateral uterine displacement. Then last, fetal assessment. Fetal monitor should be removed or detached as soon as possible to facilitate the PMCD without delay. Maternal resuscitation is the best fetal resuscitation, remember. So in summary, what is the difference in the non-pregnant, pregnant patient? Persons affected are one in non-pregnant. In pregnant patient, there are 2, mother and fetus. Chest compression, lower 1/3 of the sternum, same airway, nasal airway can be used in non-pregnant patient, but it is not used in pregnant patient because of the bleeding. So smaller size tube should be used. Intubation should be done by expert anesthetist or expert physician. Breathing, there's the hyperventilation should be avoided. A single person can ventilate the non-pregnant patient, but it requires most of the time 2 persons to ventilate the pregnant patient. Then defibrillation, same. IV assays preferably anywhere, but in pregnant patient it should be above the diaphragm, that is upper extremity. Calcium gluconate for magnesium toxicity. Then special maneuver like ECMO, UAG, then ET. Then there is a lung assistant, extracorporeal lung assistant method is there for CPR, and extracorporeal CO2 removal. Like the devices like that are also available for the CPR. So this is the conclusion. Successful resuscitation of the pregnant woman and survival of the patient require prompt and excellent CPR with some modification in technique. Thank you.
Congratulations, Dr. Avinash, for an excellent and informative lecture. You have highlighted all the problems that are associated, the precautions to be taken, and the treatment guidelines while resuscitating a pregnant patient. Not related with the topic, but I would like to ask you, will you take any special precautions before administering anesthesia to a pregnant patient?
Yes. I have already told you that prevention is better than you have to go to for CPR, because when what precaution you should take, you should pre-oxygenate the patient, any patient. When you are taking to for the pregnant patient for any surgery, it may be under spinal anesthesia or under general anesthesia. Because you should oxygenate the patient, because you will get time to resuscitate, you will get time to intubate, you will get time to ventilate the patient if you have already oxygenated the patient. So it is most important. Pre-oxygenation is pre-medication. I always say pre-oxygenation is pre-medication. You have to pre-oxygenate the patient even if the patient is under spinal anesthesia. So because the situation cardiac arrest occur even under spinal anesthesia also. So it is most important, I think. Even you can ventilate the patient with 50, if it is there is a difficulty in intubation, you can ventilate the patient, or you keep the nasal prongs to the patient and give the O2 at the rate of 15 liters per minute. That means we are using in COVID the high flow ventilator. What are the same? So give oxygenation. It will give you 10 minutes. You can't believe it. It will give to you 10 minutes for the resuscitation. So pre-oxygenation is most important. Thank you, sir. Thank you very much. Thank you, everybody.
I request Dr. Sanjay Patil sir to felicitate our speaker, Dr. Avinash Bhosle sir. I request our IMA Secretary, Dr. Deepak Thorat sir, to felicitate our chairperson, Dr. Sanjay Patil sir. Session will be our inauguration session.
Ladies and gentlemen, as we embark on this journey of knowledge and collaboration, it is with great pleasure and anticipation that we extend a heartfelt welcome to each one of you. SATCON has always been a platform for foresting innovation, sharing expertise, and building connections within the medical community, and the anesthesia workshop is a testament to that commitment. Team Anesthesia, you are at the forefront of medical excellence, shaping the landscape of patients' care through your expertise and dedication. Your presence here today signifies a shared commitment to advancing the field of anesthesiology. And we are honored to have you as an integral part of SATCON 2024. This workshop stands as a bridge between theory and practice, offering a unique opportunity for collaborative learning, knowledge exchange, and skill enhancement. Thank you, and let's begin with the inaugural ceremony of anesthesia workshop at SATCON 2024. I would like to call upon our IMA President, Dr. Sharad Jagtap sir on the dais, IMA Secretary, Dr. Deepak Thorat sir, please come, IMA Women's Wing President, Dr. Rajeshri Deshpande madam, our ISA past President, Dr. Limaye madam, ISA Secretary, Dr. Jyoti Mohite madam, Maharashtra ISA Vice President, Dr. Avinash Bhosle sir. Please welcome on the dais. Now I would like to request Dr. Madhuri Limaye madam to escort Gondhalekar madam on the dais, please. Gondhalekar madam, please come. Let's welcome Gondhalekar madam with a big round of applause. Welcome madam. Now I would like to request our Secretary, Dr. Deepak Thorat sir, to talk a few words. Sir, please.
Thank you very much, Rajashree. And it's great start today for SATCON 24. आज वर्कशॉप योग्य वेळी सुरू झालं आणि सगळ्यांनी खूप छान लेक्चर्स दिले. त्याच्यात सुरुवात गव्हर्नमेंट मेडिकल कॉलेज साताराचे पवार सर असतील किंवा ज्योती मॅडम असतील किंवा लिमये मॅडम असतील आणि अविनाश भोसले सर असतील, सर्वांनी इन्फॉर्मेटिव्ह आणि लाईव्ह माहिती दिली आणि लाईव्ह क्वेश्चन आन्सर्स पण झाले आमचे आणि खूप सुंदर असा कार्यक्रम झाला, इन्फॉर्मेटिव्ह कार्यक्रम झाला. त्याबद्दल सर्वांचे आभार. आणि हा आता कार्यक्रम पुढं आपण नेऊया आणि पुढचं इनॉग्रेशनचा कार्यक्रम घेऊया. आणि ओव्हर टू राजश्री.
Thank you, sir. Now I would like to request everyone to stand for Deepa Prajwalan. I would like to request Dr. Sagar Kataria sir to please come on the dais. Dr. Sonwalkar sir, please come on the dais. I would like to request everyone to be please seated for our today's inaugural ceremonies. There are two chief guests. One of them is our DHO sir, Dr. Mahesh Khalipe sir. He could not be present here because of some work emergency. So now I would like to request Dr. Sharad Jagtap sir to felicitate our chief guest, Dr. Gondhalekar madam. Sir, please. I would like to introduce you everyone to Dr. Gondhalekar madam. Actually, I would say मराठीत म्हणतात तसं लहान तोंडी मोठा घास. मी त्यांचं काय introduction karun do, but still I would like to tell every one of you regarding her. Madam has completed her MBBS from BJ Medical College and she shifted to Satara in the year 1972. She has completed her degree of diploma anesthesia in the year 1981-82, had worked for a couple of years in civil hospital and in Jeevan Jyot hospital. She didn't stop here, but went to famous Mayo Clinic in USA and St. Columbia Hospital in New York and had successfully did her observership over there. She is the only lady president in IMA Satara so far. In her course of administration, she has conducted many CMEs by reputed doctors like Dr. Balasaheb Deshpande, Dr. Mandke sir, and many more. She has been given anesthesia for all kinds of surgeries and just wasn't successful as an anesthesiologist in Satara, but during her medical education, she has achieved remarkable success and higher rank in her inter-college swimming competitions. She is being trained in yoga at Iyengar Institute, Pune, and has been regularly practicing yoga and has conducted yoga classes for many years. For her very inspiring and successful journey as a doctor, as a person, as a multi-talented personality, she has been acknowledged by IMA with Lifetime Achievement Award. Congratulations, ma'am. And Satara IMA is very much honored to have such a dynamic, intelligent, experienced and energetic doctor today. Now, I would like to request Gondhrekar madam to guide us with her experiences. Please, madam.
बसून नको बोलायला ओ हे असं दोन पाय ठेवून हे जीवनशूट सारखंच आहे नाही मला हे पाहिजे मला हे ठेवायचं गोर नाही जरा तरी नाही तुम्ही दिसायचीच नाही बोलू नमस्कार ऐकू येते का IMA साताराचे प्रेसिडेंट डॉक्टर शरद जगताप व्हाईस प्रेसिडेंट डॉक्टर कटारिया आणि सेक्रेटरी डॉक्टर थोरात ISA साताराचे अध्यक्ष डॉक्टर वैशाली चव्हाण आणि सेक्रेटरी डॉक्टर ज्योती जाधव आपणा सर्वांचे स्वागत मी IMA साताराची ओनली लेडी प्रेसिडेंट आणि सातारा ISAची फाउंडर प्रेसिडेंट या नात्याने आपले परत एकदा स्वागत करते IMA साताराने 2, 3, 4 फेब्रुवारी ह्याच्यामध्ये सॅटकॉन आयोजित केली आहे त्यात एक पूर्ण दिवस म्हणजे 2 तारीख ही ISA साताराच्या वर्कशॉपसाठी मिळालेले आहे सातारा ISA आधी सातारा डिस्ट्रिक्ट एनेस्थेशिया असोसिएशन होती या नात्याने ती कार्यरत होती मी 1972 मध्ये साताऱ्यात आले तेव्हा आमच्याकडे बॉईल्स मशीन बेलोज किंवा अंबू बॅग वगैरे काहीही नव्हते आम्ही एथिल क्लोराईड स्प्रे व इतर ह्याच्यावर सगळे ऑपरेशन्स करत होतो त्यावेळेचं प्रसिद्ध म्हणजे डबा बाटली हे खरं मला दाखवायला आणायचं होतं पण ते आता मला काही सापडलं नाही ह्याच्यामध्ये इथरनी 3rd स्टेज आली की ट्यूब घालायची आणि मग नंतर जसं जसं पेशंट राहील तसं इथर कनेक्ट डिस्कनेक्ट करायचं आणि ऑक्सिजन त्याला 2 भोकं असायची त्या ह्याला त्याच्यामधनं ऑक्सिजन सोडायचा आणि असे अनेक मेजर ऑपरेशन्स आम्ही त्यावेळेला केलेली आहेत नंतर मग पेंटोस कोलिन अंबू बॅग पहिल्यांदा बेलोज आलं मग पेंटोस कोलिन अंबू बॅग हे सगळं आलं आणि आता नंतर सर्व प्रकारची मसल रिलॅक्संट्स आणि इतर पुष्कळच गोष्टी आल्या म्हणजे बॉईल्स तर आलं अंबू बॅग आली बॉईल्स आलं आणि आता बॉईल्सचं त्याचं वर्क स्टेशन पण आलं 2004 मध्ये सातारा ISA ही सुरू झाली मी प्रेसिडेंट आणि डॉक्टर अविनाश भोसले सेक्रेटरी होतो 2004 आणि 2006 मध्ये महाबळेश्वर येथे आम्ही CME घेतली आणि त्याच्यानंतर ड्रीमलँड येथे स्टेट कॉन्फरन्स झाली आज येथे ISA साताराचं मोठं वर्कशॉप अरेंज केले गेले आहे ISA साताराचं नाव राज्य आणि देश पातळीवर सगळीकडे ओळखले जाते ते कारण काय तर सातत्याने घेत असलेल्या कॉम्प्रेशन ओनली लाईफ सपोर्ट म्हणजे COLS ह्याच्यामुळे आहे ते 2008 पासून 16 वर्ष मेडिकल तसेच नॉन मेडिकल लोकांना त्यांनी शिक्षित केलेले आहे. आत्तापर्यंत ISAनी किमान 500 COLS केली असतील आणि बहुतेक 20,000 पेक्षा जास्ती लोकांना प्रशिक्षित केलेले आहे. 14 वर्षे सिव्हिल हॉस्पिटल, पोलीस हॉस्पिटल, नंतर RTO ऑफिस, होमिओपॅथी मेडिकल कॉलेज, आयुर्वेद कॉलेज इथे दरवर्षी 16 ऑक्टोबर म्हणजे जो IMA वर्ल्ड IMA डे आहे तो हे केला जातो, कार्यक्रम घेतला जातो. याशिवाय MIDC फॅक्टरीज, शाळा, नंतर पोलीस मुख्यालय येथे पण कार्यक्रम घेतले जातात. तसंच छोटे गट म्हणजे बचत गट वगैरे जे असतील त्याच्यामध्ये सुद्धा हे कार्यक्रम घेतले जातात. आमचे सर्व सदस्य निस्वार्थीपणाने ही सेवा देतात. ISAच्या कामासाठी दखल राज्य आणि देश पातळीवर घेतली गेली आहे आणि त्यांना 15 वर्षे सातत्याने दरवर्षी पुरस्कार बक्षिसं मिळत गेली आहेत. आमच्या संघटनेतील डॉक्टर माधुरी लिमये, डॉक्टर अविनाश भोसले, डॉक्टर समीर सोहनी, वैशाली मोरे, वैशाली चव्हाण या सगळ्यांना अशा पुरस्काराने सन्मानित केले गेले आहे. भूलतज्ञ हा पडद्यामागील सूत्रधार असतो, त्यामुळे पुष्कळ वेळेला पेशंटना माहीत नसतं की आपल्याला भूल कोणी दिली, आपल्याला कोणी हे केलेलं. तर आमचे हे सर्व सदस्य वृत्तपत्र, आकाशवाणी तसंच YouTube चॅनल्स ह्याच्याद्वारे सगळ्या लोकांना जागृत करत असतात भूलविषयी. हे वरील सगळे उद्धृत केलेले डॉक्टर्स आणि डॉक्टर गोसावी यांनी डॉक्टर प्रकाश आमटे यांचे हेमलकसा आणि डॉक्टर अभय बंग यांचे शोधग्राम घेतलं. त्यांची सेवा विनामूल्य तिथे जाऊन दिलेली आहे. आमच्या भूलशास्त्राबद्दल व संघटनेच्या या कामाबद्दल थोडक्यात माहिती देणं हे ISA साताराची प्रथम प्रेसिडेंट म्हणून माझं मी कर्तव्य समजते. पूर्ण दिवस या संघटनेला वर्कशॉप घेण्याची संधी दिल्याबद्दल व मला उद्घाटनाचे निमंत्रण केल्याबद्दल मी IMA सातारा व सॅटकॉन आयोजकांचे आभार मानते आणि सॅटकॉन 2024ला मनापासून लक्ष शुभेच्छा देते.
धन्यवाद मॅडम. तुमच्या अनमोल आशीर्वादांनी आज खूप छान वाटलं. मॅडमनी 75 क्रॉस केली बरोबर ना मॅडम? या 76 रनिंग आणि या वयातही त्या एवढ्या एनर्जेटिक आणि उत्साही आहेत. हे पाहून आम्हाला खूप मोलाचं मार्गदर्शन मिळालं. थँक्यू सो मच मॅडम. आपण आता पुढील मी त्याआधी डॉक्टर शरद जगताप सरांना विनंती करते की त्यांनी 2 शब्द बोलून आम्हाला मार्गदर्शन करावं.
Respected Chief Guest, Dr. Gondalekar Madam, all the dignitaries of our Satara IMA, and all the present members of Anesthesiology Society of Satara. I heartily congratulate all the speakers as well as the member of the Anesthesiology Satara that they have arranged this superb workshop for not only Satara people, member of the Satara IMA, but also for the members or doctors who are involved in the online conference. The work of anesthesia Satara members, it is we know all of them, and they are working very hard to go this type of life-saving measures in the periphery as well as in the society, and their work will be counted forever. Thank you all of you, and we will continue with this conference for 2 days. The same cooperation is required from all of the members. Thank you.
Thank you, sir. Now we will start with our remaining workshop. I will request all the dignitaries to please have a seat on the other side of the dais. We will start with our next lecture very soon. is by Dr. Asha Barge Madam. Asha Barge Madam, she's a pain specialist in Satara. I would like to introduce her.
I request Dr. Samir Soni sir to chair this session and Dr. Motling sir.
Dr. Asha Satish Barge is our first speaker. Dr. Asha Barge, Director and Head Barge Pain Clinic and Mangal Murthy Hospital, Satara. Please, ma'am, start the lecture.
I am Dr. Asha Satish Barge. Today I am going to present a topic on pre-anesthetic evaluation. So the outcome of any anesthetic is determined by how well prepared the anesthesiologist is to handle that particular patient. Pre-anesthesia evaluation is defined as the process of clinical assessment that precedes the delivery of anesthesia care for surgery and for non-surgical procedures. Perioperative refers to the care surrounding operations and procedures. The pre-anesthetic evaluation is the responsibility of anesthesiologist. Pre-anesthetic assessment, pre-anesthesia evaluation, and pre-anesthesia checkup, all these are similar terminologies. And a pre-anesthesia checkup is the process of clinical assessment that precedes the delivery of anesthesia care for surgery and for non-surgical procedures. This includes review of patient's medical records, interview of the patient, physical examination of the patient, and investigations. This is the first introduction of anesthesia to the patient. It reduces patient's anxiety before surgery and may even decrease post-operative pain and length of hospital stay. The goals of pre-anesthesia checkup are evaluation of patient's general health and optimization if necessary, anticipation of possible complications and planning to avoid them. The objectives of pre-anesthesia checkup, they are developing good doctor-patient relationship, to obtain patient's data, to make a good anesthesia plan, and to obtain patient's consent. The steps of pre-anesthesia visit are to identify if there is any problem. We have to assess any risk if it is there. Then we have to prepare pre-operatively for the situation and make a plan of anesthesia technique. So history remains the base or the bottom line of pre-anesthesia checkup. So we have to identify the patient, patient's name, age, sex. We have to review the file of the patient. We have to see for pre-operative diagnosis, what is the surgery which is planned, and we have to decide the mode of anesthesia, whether regional anesthesia, local anesthesia, or general anesthesia. So we have to see for history of any previous anesthesia, whether the patient is allergic to any drugs, whether there is history of post-operative nausea, vomiting, then whether the patient was exposed to halothane or any volatile anesthetic agents within 3 months prior to surgery. There is history of whether there is history of anesthesia awareness, history of difficult intubation, or history of delayed emergence. Then we have to look for past medical history of diabetes mellitus, hypertension, COPD, coronary artery disease, or thyroid disease. Whether the patient is on regular medications, previous surgeries, whether patient has undergone previous surgeries. If yes, then what was the date? What was the anesthesia given? Then we have to see for personal history of smoking, alcohol abuse, drug abuse. Then family history. In family history, we have to look for problems with anesthesia in family, such as pseudocholinesterase deficiency and malignant hyperpyrexia. Then we have to see for menstrual history in case of females, whether there is history of pregnancy. If yes, then we have to ask for last menstrual period, LMP. Then we have to review our systems like respiratory system, upper respiratory tract, we have to ask for cough, cold. Lower respiratory tract, we have to ask for shortness of breath. Then we have to see cardiac system, central nervous system, GI system. Oral cavity, we have to see dentures, loose teeth or cap teeth. Per abdomen, whether there is any tenderness, rigidity, and urogenital system. In examination, in general examination, we have to look for weight, BMI, then pallor, icterus, lymphadenopathy, cyanosis, clubbing, edema, dehydration. We have to see for vital signs, then SpO2, pulse rate, blood pressure, temperature, respiratory rate. In systemic examination, we have to see chest, cardiovascular system, per abdomen, and central nervous system. In local examination, we have to see for any deformity in the spine. Then in nasal cavity, we have to see for deformity, any obstruction. In oral cavity, we have to see teeth, tongue, dentures. And we have to also see whether the peripheral venous access can be obtained. Then in evaluation, we have to look for different criteria. And mnemonics is lemon. The L is look externally, that is facial trauma, large incisors, beard or mustache, large tongue. Then E is evaluate the 3-3-2 rule, that is incisor distance 3 finger breadths, hyoid mental distance 3 finger breadths, thyroid to mouth distance 2 finger breadths. Malampatti criteria, Malampatti score should be more than 3. And whether there is any obstruction, presence of any condition like epiglottitis, peritonsillar abscess or trauma. And in neck, we have to look for any limited neck mobility. Then we have to again see the mental distance. If it is more than 7.5 centimeter, it is normal. If it is between 6 to 7.5 centimeter, we have to be cautious. And if the TM distance is less than 6 centimeters, it is a warning for us. And we have to see the mouth opening. If it is more than 4 centimeters, then it is good on normal condition. If the mouth opening is between 3 to 4 centimeters, we have to be cautious. If the mouth opening is less than 3 centimeters, then it is a warning for us. Then we have to see for neck extension. If it is more than 30 degree, it is good. If it is less, it is between 10 to 30 degree, we have to be cautious. And if it is less than 10 degree, then it's a warning for us. Then upper lip bite test, grade 1 and grade 2, we can intubate easily. But grade 3, we have to do by video laryngoscopy. And grade 3 is intubation is done by fibroscope. And grade 1 and 2, direct laryngoscopy. So this is a picture showing upper lip bite test. So in class 1, lower incisors can bite the upper lip above the vermilion line, whereas class 2, lower incisors can bite the upper lip below the vermilion line, whereas class 3, lower incisors cannot bite the upper lip. And this is a Malampatti scoring. Score 1 is when we visualize soft palate, fauces, uvula, and anterior and posterior pillars. Class 2, anterior posterior pillars are not visualized. Only soft palate, fauces, and uvula is visualized. Class 3 is only soft palate and base of uvula is seen. Whereas class 4, the hard palate but not the soft palate is seen. And in class 1 and class 2, generally easy intubation. Whereas class 3 and class 4, we have to anticipate difficult intubation. So now we have to proceed for investigations. Basic investigations, they include complete blood count, hemoglobin, total count, differential count, ABO-RH typing, random blood sugar, urea creatinine, electrolytes, PT, INR, prothrombin time and INR, urine routine microscopic examination, chest X-ray, ECG, serology. And other tests which, if needed, we have to go for ECG, thyroid function test, HbA1c, BTCT, APTT, liver function test, and pulmonary function test. Anemia is common in India, particularly due to iron and other nutritional deficiencies. Understanding the etiopathogenesis of anemia may be more important than just measuring the HB values. It may allow for the timely treatment of causes of anemia like iron deficiency anemia. And anemia can be a reason to cancel or postpone the surgery. So timely treatment of the cause of anemia is very important. Random blood sugars, fasting or postprandial, and HbA1c is the commonly advised test, especially when a patient has crossed 40 years of age. There is no role of offering an HbA1c in patients without a diagnosed diabetes mellitus. In their guidelines from Baker's P. et al., they have mentioned that random blood glucose test has no role to play in planning management. As diabetes mellitus is an emerging disease in India, as well as patients may often be unaware of the health issues or may have poor access to healthcare, many experts from South Asia have favored considering blood glucose level by glucose tolerant test in pre-anesthetic checkup. We have observed that other investigations often ordered routinely are ECG and X-ray chest. X-ray chest is a standard part of PSC in India. In Indian study by Chandra A. et al. Had 11% abnormal findings of chest on X-ray chest done in pre-anesthetic checkup. Of these, only 2% had intraoperative bronchospasm, which was managed by bronchodilators and steroids without any complications. Another practice often observed is ordering ECG routinely. There is low prevalence of abnormal ECG in a young patient of less than 45 years of age. Finding a significantly abnormal ECG in a patient with no history of cardiac disease is very rare. So we have seen that multiple factors influence the prescribing pattern of preoperative tests. Several practitioners, they believe prescribing routine investigations may serve as a valid defense in case of litigations. But it is not known how many times routine preoperative testing contributed to the defense of anesthesiologists and surgeons involved. So this is a classification by American Society of Anesthesiologists. They have mentioned 6 grades of ASA classification. Class 1, ASA grade 1 is normal healthy patient. ASA grade 2 is a patient with mild systemic disease. ASA grade 3 is a patient with severe systemic disease. ASA 4 is patient with severe systemic disease that is a concentrate to life. Whereas ASA 5 is moribund patient who is not expected to survive without any surgery, without the surgery. ASA 6 is declared brain dead patient whose organs are being removed for donor purposes. And this graph shows that the deaths related to anesthesia are very less in ASA grade 1, whereas in ASA grade 5, the deaths are maximum. Now, then we have to find out what medications are going on preoperatively. If the patient is on levothyroxine, we have to continue on day before OT and on OT day. Then calcium channel blockers, we have to continue both on before OT and on OT day. Beta blockers also we have to continue day before OT and OT day. Whereas AC inhibitors and angiotensin receptor blockers, we have to continue day before OT, but we have to hold on OT day. Diuretics, we have to continue day before, but we have to hold on OT day. Metformin, we have to hold both day before OT and on OT day. Oral hypoglycemic agents, We have to continue day before, but we have to hold on OT day. And inhaled bronchodilators, we have to continue on both day before OT and on OT day. So different societies, they have laid different guidelines for preoperative fasting. The latest guidelines by ASA, that is American Society of Anesthesiologists, uh, in 2018, they have laid guidelines for preoperative fasting. In that, they mention for adults also and for pediatric patients also, no fasting is required for moderate sedation, whereas for deep sedation, fasting is recommended. So ASA fasting guidelines are for clear fluids, we can give 2 hours prior to surgery. That includes water, fruit juice without pulp, carbonated beverages, clear tea, black tea. And in milk, if you are giving human milk, we have to give 4 hours prior to surgery, whereas infant formula can be given 6 hours prior to surgery. Light foods can be given 6 hours prior to surgery. That includes fruits, juices with pulps and vegetables, whereas heavy foods that can be given 8 hours prior to surgery, which includes fatty meals and meats. So the conclusion is there is a pressing need for national guidelines designed and tailored according to the disease profile of Indian patient. The value of a thorough history and physical examination is critical and cannot be replaced by routine investigations. A selective approach for ordering investigations in a pre-anesthetic checkup setting for elective surgeries in patients in ASA grade 1 and 2 seem prudent. The use of bedside tests like breath holding tests, methodical questionnaires, and cardiopulmonary exercise testing may be recommended. They are cheap and easy to administer. These are my references. So thank you so much.
Very nicely presented by Dr. Asha. It's being a IMA conference. I know there are all sorts of medicos attending this conference. What we wanted to convey through this lecture is the role of pre-anesthesia checkup in every surgery, let it be major or a minor one, to be considered very seriously by all the medicos who are posting a patient for surgery, let it be a general practitioner or a hospital owner or any kind of surgeon. It's prudent to have a properly evaluated patient before posting for any surgery. Thank you.
I will request Dr. Soni sir and Motling sir to be remain as a chairperson for next session also.
Yes, sir, and thank you, sir, for putting on light on this topic. And we'll continue this session with a pre-recorded video. We'll play the video right now and we'll continue the session, please.
We will learn about the preparation and equipments that are needed for intubation and the role of a nurse to ensure that all those equipments are working properly. The use of each equipment in the process of intubation is explained for better understanding. On that note, let's get started. As a standard procedure, first of all, do not forget to take consent for intubation. IV cannula. Check the patency of the IV cannula or the central line available for pushing the medications during intubation. If there is any block, place a new IV line for use. Laryngoscope. Laryngoscope is used to expose the laryngeal inlet under direct vision or line of sight to facilitate placement of tracheal tube beyond the vocal cords. Check if the blade fits properly with the handle. Check if the light source is working properly even when the blade is stretched. Make sure that there are no jiggly parts in the laryngoscope. The laryngoscope should be sturdy. Ensure that the bulb is tightly screwed and not jiggling. Keep 2 extra pairs of laryngoscope batteries with you, which may be useful in case of emergency. This is laryngoscope handle. This curved blade of laryngoscope is called Macintosh. This straight blade of laryngoscope is called Miller blade. Keep different types and sizes of endotracheal tubes ready like cuffed, uncuffed, subglottic and any other type of ET tubes as advised by the doctor as needed. By opening only a small portion of the wrapper of the ET tube, check if there is any leak of ET tube cuff. Keep a xylocaine jelly ready, which is used in a few hospitals to apply at the tip of the endotracheal tube for lubrication before passing it into the trachea. 10 ml syringe to inflate and deflate the ET tube cuff when required. Ambu bag for ventilating the patient. Ambu bag and mask should be attached to a oxygen source. Different sizes of ambu masks which are useful for pre-oxygenating the patient. Bougie, which can be used as a guide wire to easily advance an endotracheal tube into the trachea. Stylet. Stylet is an instrument which can be used to change the shape of the ET tube the way we want. Stylet can be used to easily pass the ET tube into the trachea in case of difficult intubation. Capnometer. Capnometer displays the concentration of carbon dioxide in exhaled air. It helps in confirming the position of the endotracheal tube. Loaded and labeled syringes of medications which are used during intubation like rucronium, vecuronium, fentanyl, succinylcholine, propofol, etc. We must also keep loaded and labeled syringes of emergency drugs ready during intubation, which will come in handy in case of emergencies. Apparatus for suctioning like suction set, suction catheters, normal saline or sterile water, central suction apparatus or portable suction apparatus are necessary to clear secretions and to maintain patency to increase oxygenation during intubation. ET tie. ET tie for securing the position of the endotracheal tube. Dynaplaster. Dynaplaster is used to secure the oral airway. But in some hospitals, dynaplaster is used in place of ET tie for securing the endotracheal tube. Keep a stethoscope ready for checking the bilateral air entry. Make sure to arrange personal protective equipment, that is PPE, like cap, face mask, gloves, gown, etc. for you and all others involved in the intubation process. Keep ready different sizes of laryngeal mask airway and a tracheostomy kit with different sizes. These can be used in case of failure to intubate with the endotracheal tube. Keep a calibrated mechanical ventilator ready with its hosepipe tips properly fitted in its oxygen and air pressure ports, and make sure that the power source for the ventilator and syringe pumps is working properly. Keep the ventilator tubings, catheter mount, servo guard, HME filter ready so that we can connect the endotracheal tube to the ventilator after we finish intubating. Oral airway for use if you suspect the intubated patient may bite the endotracheal tube. Employing nasal oxygen using a nasal cannula during intubation can prevent hypoxia. It extends safe apnea time and improves first pass success attempts. The time period between becoming apneic and oxygenated via intubation is a vulnerable moment in the patient's oxygen status. This suspected hypoxia can possibly be reduced by using a nasal cannula. Magill forceps. Magill forceps are used to guide the endotracheal tube into the laryngeal inlet during nasotracheal intubation or a nasogastric tube into the esophagus under direct vision. It is also used in the removal of foreign bodies during intubation. Keep all the colored dustbins within reach to discard the waste. Rails tube. Placing a rails tube can prevent aspiration if we do not know when the patient last had food. Try to label each equipment clearly with capital letters so that it is easy for you to pass each equipment to the doctor who is intubating according to the sequence of steps involved in the process of intubation. So these are the equipments and preparation that you need to follow before intubation. If there are any other equipments that you use and any other preparation that you do other than this, please comment below. If you like this video, don't forget to hit that like button. Thanks for watching.
Nicely demonstrated the various aspects of material and equipments to be used in OT by all of us anesthesiologists. Thank you.
Let's start with her new topic, selection of IV fluids by Dr. Mugdha Mahajan. She's MD anesthesia, gold medalist in MD exam, did her DNB in December 2018 and now working as assistant professor at KIMS, Karad. Dr. Mugdha, please throw some light on selection of IV fluids.
A very good evening to all the dignitaries who are present today, and a very warm welcome to all the delegates attending it online. My topic I'm Dr. Mugdha Abhishek Mahajan, and I'll be presenting selection of IV fluids. So let's begin with the basic physiology. Our body consists of 60% of the water, which is distributed in 2/3 amount in the intracellular fluid, whereas 1/3 in the extracellular fluid. The extracellular fluid is further divided into interstitial fluid and plasma. And the amount of water in case of children is 80% of their body weight. So we'll consider the electrolyte composition of ICF and ECF in order to know the composition and the physiological principles of different IV fluids used better. So first we'll begin with sodium. It is approximately 142 milliequivalent per liter present in the ECF. Chloride is present in 104 milliequivalent per liter concentration, and bicarbonate is 24 milliequivalent per liter concentration in ECF, whereas potassium is high in intracellular fluid, which is 150 milliequivalent per liter, and along with calcium and other ions, which are mainly ICF. So sodium chloride and bicarbonate are mainly extracellular, whereas potassium and calcium are mainly intracellular. The plasma osmolality. Osmolality of any solution is defined as the amount of solute that is dissolved in a solvent, which is measured in weight, that is in kgs. The plasma osmolarity is mainly determined by sodium and with lesser contributions from other ions, glucose and urea. The normal plasma osmolality is 285 milliosmol per kg. This is very important because all the IV fluids, be it crystalloid or colloid, will be compared to this plasma osmolality and classified into hypoosmolar, isoosmolar and hyperosmolar. So why choice of IV fluids is so important for all of us? IV fluids have been increasingly considered these days as drugs with dose recommendations, indications, contraindications and side effects. There were vigorous debate that developed regarding the choice of fluid, mainly focusing on the importance of avoiding hyperchloremic metabolic acidosis, which was induced by large volumes of NS infusions and development of acute kidney injury and impaired hemostasis, which happened with HES. Now, the history of IV fluids. The first IV fluid was developed by Ringer in order to mimic blood plasma for his ex vivo experiments with frog hearts. In 1932, Hartmann and Sen, they added buffer lactate to Ringer solution and created the first balanced crystalloid, which is rampantly used nowadays, that is Ringer's lactate. Jacob Hamburger was the one who developed NS, normal saline. The use of colloids became more common with the infusion of albumin in trauma patients during World War II. Now this is a chart which is demonstrating the pH, osmolarity, sodium and chloride and potassium concentrations of the different crystalloids that are used. So we'll just focus on a few of them. First, we'll begin with normal saline. 0.9% normal saline has a pH of 5.5. So it's slightly acidic as compared to plasma, and slightly hypertonic. That is, the osmolarity is 308 milliosmoles with a sodium and chloride concentration being 154 each. Then talking about the half normal saline, which has the same pH, but it is hypoosmolar, approximately 155 milliosmolarity, and half the concentrations of sodium and chloride as compared to NS. Then there are other IV fluids that we'll be talking about in details in the coming slides. Next is 5% dextrose, which has a pH of 4.3 and a osmolarity of 253 without any electrolytes. So now let's focus on the crystalloids first. The IV fluids have been broadly classified under crystalloids and colloids. The examples of crystalloids being isotonic, hypotonic, and hypertonic. Isotonic includes normal saline 0.9%, Ringer's lactate, and glucose water. Hypotonic is half normal strength normal saline and glucose saline, and hypertonic is 3% normal saline and 10, 20, 50% of glucose water. The colloids will be discussed later in details. So we'll begin with isotonic saline 0.9% ACl. The composition of isotonic saline is 1 liter of NS contains sodium and chloride in a concentration of 154 milliequivalent each, and 100 ml contains 0.9 grams sodium chloride. Now mainly sodium and chloride are present in the ECF, so isotonic saline is mainly distributed to the extracellular fluid, and it increases the plasma volume. What are the indications? It's useful for correcting fluid and electrolyte loss in vomiting, diarrhea after RL. Then this fluid is mainly distributed in the ECF compartment, thereby increasing the intravascular volume. So it is basically useful for increasing blood pressure in hypovolemic shock. This fluid can be safely given with blood, and it's also initial fluid of choice in diabetic ketoacidosis. What are the contraindications? Dehydration in which the patient is having severe hypokalemia. Giving just NS without any potassium in it will further aggravate hypokalemia. Next is RL. This Hartmann solution is the most physiological solution, as we all said, because the composition includes sodium in 131 milliequivalent per liter, potassium 5, chloride is 111, calcium is 3, and lactates is 28 milliequivalent per liter. Lactate gets okay, I'll tell that in detail later. Osmolarity is 280 milliosmoles, so it is closest to our plasma. It's the most physiological fluid, as I already told you. So there is no risk of causing electrolyte imbalance, and you can infuse it in large amounts. And the sodium lactate is getting metabolized to bicarbonate, so it's useful for correcting the metabolic acidosis. The indications include correction of severe hypovolemia rapidly. It's a replacement fluid for post-operative patients. Fluid of choice for hypokalemic metabolic acidosis that is seen in diarrhea. And it's also a fluid of choice after using NS in DK. Then what are the contraindications in liver disorders? It is contraindicated because the lactate doesn't get metabolized to bicarbonate, and therefore it induces metabolic acidosis. In severe CHF, there is hypovolemia along with decreased peripheral circulation, so there is pre-existing metabolic acidosis. So by giving RL, you are going to further worsen the metabolic acidosis. In Addison's disease, there is hyperkalemia because of deficiency of aldosterone, so it will further aggravate the hyperkalemia. Severe metabolic acidosis because the lactate that gets deposited or along with the RL cannot rapidly get converted into bicarbonate. So this basically aggravates the metabolic acidosis further, and you cannot give it with blood transfusion because it will clot the blood. Then dextrose normal saline composition includes 1 liter of sodium and chloride in the same amount as normal saline along with 50 grams of sugar. Each 100 ml therefore contains 5 grams of glucose with 0.9 grams of sodium chloride. It provides basically energy along with other electrolytes, and like our normal saline, it gets distributed to extracellular fluid. So it causes or rather provides glucose, but if given in a large volume, it will lead to hyperglycemia induced osmotic diuresis. The indications of DNS are correction of salt and glucose insufficiency, typically with dehydration and vomiting. The contraindications include hypervolemic patients with cardiac, renal, and liver disease. Hypovolemic shock patients, the rapid replacement leads to osmotic diuresis, so it will rather worsen the hypovolemia. And in traumatic brain injury and neurosurgery patients, hyperglycemia basically further aggravates the damage caused to the blood-brain barrier, therefore it should be avoided. 5% dextrose. It has plain 50, like 1 liter has 50 grams of glucose with no electrolytes. The pharmacological basis, it just corrects the hypoglycemia, and thereby because the glucose gets absorbed or it shifts from the intravascular compartment into the intracellular spaces, it corrects the intracellular dehydration. The indications are prevention and treatment of dehydration due to excessive water loss, to provide glucose, and correction of hypernatremia due to diabetes insipidus. How it corrects hypernatremia? It's basically hypoosmolar, so it will reduce the osmolarity of the blood. So it will draw the sodium from the interstitial spaces into the intravascular compartment. The contraindications of 5% dextrose include cerebral edema, neurosurgical procedures, acute ischemic stroke, and hypovolemic shock. The next is 5% dextrose with half normal saline. It has 1 liter has sodium and chloride in a concentration of 77 milliequivalent each with 50 grams of glucose. The osmolarity is 406 milliosmoles per liter. The pharmacological basis is it contains 50% salt as compared to NS or DNS, and it is used whenever there is need for calories, more water, and lesser salt replacement. The indications are it can be used in as a fluid therapy in pediatric patients and treatment of severe hypernatremia, as it corrects the hypernatremia gently without causing cerebral edema. The contraindications are hyponatremia and severe dehydration due to vomiting or diarrhea. The next is isolite G. It 1 liter contains glucose in 50 grams concentration, sodium 65 milliequivalent per liter, potassium 17, chloride 150, and ammonium in 69 milliequivalent per liter. It is the ammonium gets converted to urea and hydrogen ions by the liver. So it's basically, the G stands for gastric replacement. It's a gastric replacement solution. It acts by replacing all the electrolytes lost by gastric juices and corrects the metabolic alkalosis because of release of hydrogen ions by converting ammonia into hydrogen and urea. The indications are in vomiting and in continuous nasogastric aspiration in treatment of metabolic alkalosis. Whereas the contraindications are hepatic failure, because if the liver is not going to work, the ammonium gets on accumulating and it leads to hepatic precoma like condition. Renal failure because it aggravates the uremic acidosis by releasing hydrogen ions and causing hyperkalemia. Metabolic acidosis because it is releasing hydrogen ions, you cannot use it in patient who is acidotic, and as an initial therapy in vomiting associated with shock because of its poor ability to raise the blood pressure. Isolite M. M stands for maintenance. So 1 liter of fluid contains glucose in 50 grams concentration, sodium is 40 milliequivalent, potassium is 35, chloride is 38, and acetate is 20 milliequivalent per liter. It contains electrolytes that are similar to the maintenance requirements of our body. So it also corrects acidosis along with being the richest source of potassium. The indications are mainly it's ideal for maintenance and to correct hypokalemia secondary to vomiting and diarrhea. The contraindications include renal failure because it is the richest source of potassium. It will further aggravate the hyperkalemia. Hyponatremia and water intoxication due to low sodium concentration, it can aggravate hyponatremia further. Adrenocortical insufficiency because of already pre-existing high potassium levels, this is not an ideal solution. And in burns patients, they also have cellular trauma, so there is release of potassium from the cells into the circulation, so this fluid is not suitable for burns patient. Then is isolate E. 1 liter of isolate E is having glucose as in 50 grams concentration, sodium is 140 milliequivalent, which is close to NS. Chloride is 103 milliequivalent, acetate is 47, and the remaining calcium and magnesium are also there. So it is the only fluid which has magnesium, and the E stands for extracellular replacement fluid, as its electrolytes concentration is similar to that of ECF except the double of concentration of potassium and bicarbonate. The indications are diarrhea, metabolic acidosis, and maintenance fluid preoperatively. The contraindications include metabolic alkalosis due to vomiting and alkalosis due to diuretic use or sodium bicarbonate use. Colloids. So we are moving on to the second type of IV fluids, that is colloids. Colloids are basically large molecules which when infused into the circulation are retained within the intravascular compartment. It is more effective than crystalloids as plasma volume expanders, and it is 3 point more potent than crystalloid for increasing the plasma volume. They are mainly preferred in hemorrhagic shock with hypovolemia till the time blood is made available, but they cannot replace blood because they do not increase the oxygen carrying capacity of blood. So just it is going to increase the blood pressure, increase the plasma volume, but it is not going to correct the lactic acidosis because of lack of hemoglobin. The classification of colloids, the natural ones include whole blood and fresh frozen plasma, and the synthetic ones are 6% hydroxyethyl starch, and there are different concentrations of that. Then there is pentastarch and tetrastarch. So I will be covering it one by one. They are all called balanced colloids because along with having the colloid large molecules, they also have electrolytes in them. So they also supply electrolytes along with increasing the intravascular volume. So the first one, this is a chart showing the plasma volume expansion and the duration by each colloid. So first is 5% albumin. It causes and this plasma volume expansion is by 100 per 100 ml of the fluid infused. So for 100 ml of 5% albumin, it is going to increase the plasma volume by 70 to 130 ml, and the effect stays for 16 hours. Same is the case, the duration is same with 25% albumin. However, it is more concentrated, so it will increase the volume further to approximately 500 ml. 6% hydroxyethyl starch, which is commonly used, it is going to increase it by 100 to 130 ml, and the effect is going to last for 24 hours. 10% HES is going to increase it by 150 ml, and effect is for 8 hours. The dextrans are also in 2 concentration. 10% the effect will last for 6 hours, and 6% the effect lasts longer for 12 hours. So how do the colloids act? So this can be explained by the Starling's forces. Starling principle states that the fluid movements from the capillaries to the interstitium are basically governed by four pressures. These include capillary hydrostatic pressure, which drives the fluid from the capillaries into the interstitium, plasma colloid oncotic pressure, which attracts the fluid from the interstitial compartment into the intravascular compartment. Interstitial fluid pressure, hydrostatic pressure, and interstitial fluid colloid oncotic pressure have the similar effects. It is an interplay of all these four forces. So our colloids are going to increase the plasma colloid oncotic pressure, thereby drawing fluid from interstitium into the intravascular space. So it's first is it's a Albumin. So it's physiological plasma protein in maintaining the normal plasma on the like 75% of plasma oncotic pressure. It's heat treated preparation of human albumin available as 5% and 25% solution. The pharmacological basis I've already explained. It causes the shift from the extravascular space to the intravascular space. The indications of albumin are, it causes correction of hypoproteinemia in liver disease, nephrotic syndrome, and it causes plasma volume expansion in acute hypovolemic shock and burns. The adverse effects include allergic reactions including anaphylaxis and pulmonary edema due to circulatory overload. The contraindications are, it is contraindicated in cardiac failure patients and dehydrated patients who will be requiring additional fluids along with albumin infusion. The rate of infusion is 1 ml per minute. But albumin is very expensive, so it is not routinely used. So we use the other colloids. The first one is Hemaxil. So first one is Hemaxil. It is available as 500 ml bottle with 3.5% solution. So this is a polymer of degraded gelatin, which is in 35 gram concentration. Along with that, there are other electrolytes like sodium and chloride in 145 milliequivalent per liter, and calcium and potassium. The indications are, it is going to cause rapid expansion of the intravascular space and correction of hypotension in shock, trauma patients and intra and post-operative blood loss patients. And it is prophylactically used in major surgery to reduce the volume of fluid replacement. The side effects include hypersensitivity reaction and bronchospasm. Dextrans. These are glucose polymers that are produced by bacteria incubated in the sucrose medium. It is available in two forms with a molecular weight of 70,000 and 40,000. That is Dextran 70 and Dextran 40 each. Then it is basically also important, along with the plasma volume expansion, it is also useful for maintaining microcirculation and prevention of thromboembolism. The side effects are acute renal failure in patients who are having reduced renal capacity and urinary output. So it should be given along with crystalloids and hypersensitivity reaction. So for us to use colloids, you cannot just run it like normal saline in in very high drip rate. You have to start it gradually, see that the patient is not having any hypersensitivity reaction or bronchospasm. You have to also observe their urine output when you are using colloids. Then, those were the colloids. Now we will come to the practical points or aspects. When are you going to give IV fluids? You need to give them for resuscitation, that is whenever there is acute volume loss, for rehydration in cases of vomiting, diarrhea, and maintenance in perioperative period in hemodynamically stable patients. What are the indicators of hypovolemia? So when will you suspect that the patient is going to need resuscitation with IV fluids? Whenever there is heart rate of more than 90 beats per minute, blood pressure, systolic blood pressure coming down to less than 100 mmHg. So hypotension and tachycardia is showing that the CVS is decompensated. It cannot compensate without IV fluids further. Orthostatic hypotension, that is, there is decline in the systolic blood pressure of more than 20 mmHg or a diastolic blood pressure of more than 10 within 2 to 5 minutes of standing upright after 5 minutes of supine rest, and a respiratory rate of more than 20 per minute with a urine output. So it depends upon the weight. Less than 0.5 ml per kg per hour shows that the patient is severely dehydrated and you need to give IV fluids. Then what are the physical examination findings? There are capillary refill, that there is a prolonged capillary refill, skin turgor is dry or wrinkled, there are sunken eyes, peripheral pulses are not palpable, then cold and clammy extremities, mucous membranes and JVP. The laboratory findings, just to run up, the hemo concentration is an ideal laboratory investigation to find out whether the patient is adequately hydrated or not. There is hemo concentration because of increase in RBC volume as compared to intravascular volume. The serum, even your RFTs are deranged, urea increases, LFTs are also elevated. Then how much fluid we are supposed to give. This is calculated based on the body weight. So for first 10 kgs we will give, these calculations are for per day. So for first 10 kgs we give 100 ml per kg per day per 24 hours. For next 10 kgs we give 50 ml per kg per day, and for more than 20 kgs we give 20 ml per kg per day. So for example, for a patient of 70 kg, the first 10 kgs patient is going to require 1000 ml. The next 10 kgs he is going to require 500 ml, and the remaining 50 kgs will be patient will require 1000 ml. So the total fluids per day would be 2.5 liters, and so accordingly you can calculate it by dividing by 24 hours per hour. Or there is, in pediatric patients, there is a formula used called as, it was developed by Holiday and Segar. So that formula states for first 10 kgs we will give 4 ml per kg per hour of fluid, and for next 10 kgs 2 ml per kg per hour, and for more than 20 kgs we give by 1 ml per kg. So for a normal IV drip set, 15 drops will decide 1 ml, and for a micro drip 60 drops. Then replacement of the, this is also for blood. For each ml of blood that is lost, 3 ml of crystalloids are replaced, or 1 ml of colloid is replaced. Then replacing third space losses is also very important. If it is a minimal surgical trauma patient, for example hernia, knee surgery, 0 to 2 ml per kg per hour is sufficient. For a moderate surgical trauma like hysterectomy, cholecystectomy, 3 to 4 ml, and a severe surgical trauma like exploratory laparotomy, we need to give 4 to 6 ml per kg per hour. Hypovolemic shock, the first fluid of choice will be isotonic saline till the time urine output is established, following which is Ringer's lactate. And colloids or blood, so I have already told till the time blood is made available, colloids are used. Then these are the fluid requirements. I'll just cover it in 2-3 minutes in special medical conditions. First is liver cirrhosis. In liver cirrhosis, RL should be used cautiously because the hepatic conversion of lactate doesn't happen and patient will end up in metabolic acidosis. In ascitic tapping, there is sequestration of fluid into the peritoneal cavity. So whenever there is ascitic tapping, the patient will end up in hypovolemia. In order to avoid that, it should be done with plasma volume expansion with albumin and other colloids. Then in renal disorders, RL, again NS is preferred because it is not having potassium, and RL will lead to hyperkalemia. Hypertension, sodium-rich crystalloids should be avoided like NS and DNS, or it can be used cautiously. RL can be used safely. And even in gestational hypertension or pregnancy-induced hypertension, the permeability of vascular endothelium is high, so fluid should be used cautiously in order to avoid pulmonary edema. In asthma or COPD patients, there is already hyperkalemia because of frequent use of beta-2 agonists, so RL has to be used cautiously. Then neurological disorder patient, you have to avoid hypotonic and hypoosmolar fluids like 5% dextrose because they cause cerebral edema, and also dextrose causes damage to the blood-brain barrier further. RL is an appropriate choice. First fluid choice of fluid would be isotonic saline. Thank you.
Thank you, Dr. Mugdha. Now I would like to request Dr. Sharad Jagtap sir to felicitate Dr. Motling sir and Dr. Sohni sir and Dr. Mugdha also. Sir, please. Limay madam, please join for the felicitation and felicitate Dr. Mugdha for such a lovely lecture. Thank you, Dr. Mugdha. Now I would like to request Sharad Jagtap sir to felicitate Dr. Motling sir. Dr. Sohoni sir, our senior anesthesiologist. Thank you, Dr. Motling sir and Sohni sir, for your valuable time. Now, I would like to request Dr. Shashi Patil madam and Dr. Vaishali More madam to chair next session. Madam, please come. I would like to call Dr. Mrinmai to continue with the next session. Please come, Dr. Mrinmai. Dr. Mrinmai is a MD anesthetist and she has been practicing here since last
4 years.
Since 2014? 19, sorry. Dr. Mrinmai, please continue.
My today's topic is selection of blood and blood products. Blood and blood products. Blood is the connective tissue consisting of plasma and cellular components. Average human has 5 liters of blood and that is 8% of the total body weight. It is transporting fluid that carries vital substances to all parts of the body. Properties of blood. Color. Oxygen-rich blood is scarlet red, bright crimson. Oxygen-poor blood is purple red. pH is 7.35 to 7.45. Temperature is 38 degrees Celsius or 100.4 degree Fahrenheit. Viscosity, it is 5 times more viscous than water. As blood composition, blood is the 8% of the total body weight. Further, blood is divided into plasma, that is 55%, and formed elements, that is cellular component of 45%. Plasma is further divided into proteins 7%, water 91%, and other solutes 2%. Proteins contains major part of albumins 57%, globulins 38%, fibrinogen 4%, and prothrombin 1%. Other solutes are ions, nutrients, waste products, gases, regulatory substances. Out of cellular components, major part, that is more than 99%, are of erythrocytes, and less than 1% is leukocytes and platelets. Leukocytes are further divided into neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Blood transfusion. Blood transfusion is transfusion of whole blood or its components such as blood cells or plasma from one person to another. It involves 2 procedures: collection of blood from donor and administration of blood to the recipient. Blood for transfusion is safe when donated by carefully selected healthy donor, free from infections, processed by reliable methods of testing, component production, storage, and transportation, transfused only upon need and the patient's health and well-being. These are the must things to be noted while before the blood transfusion. That is, recipient's consent is must, type and volume of each unit transfused, blood group of each unit and cross-matching done, time at which the transfusion is started should be noted, signature of the individual responsible for the administration, monitoring of patient's vitals at the initiation and completion of the transfusion, time of completion of the transfusion and transfusion reactions, if any, and its management. Pre-transfusion testing, which is done, is for major infections like hepatitis B, C, HIV 1-2, syphilis, malaria, ABO antigens, and RHD. Precautions to be taken during transfusion. Use sterile apparatus. Blood bag should be checked. Temperature of the blood to be transfused must be same as the body temperature. Transfusion rate must be slow in order to prevent increased load on heart. Careful watch on the recipient's condition for 10 minutes. Now, what is transfusion strategy or trigger for the blood transfusion? These are based on the studies. Today, there are two strategies, that is restrictive strategy, HB value less than 7 gram per dl, and liberal strategy, HB less than 10. Many studies shows that clinically, no advantages are associated with liberal transfusion policy over restrictive. Most of these strategies are directed towards anemia in stable patients who are not actively bleeding. So those who are actively bleeding and having cardiovascular disease should be subjected to more liberal strategy according to the symptomatic and clinical examination of the patient. Vital signs of the patient is also very important consideration. Peri of blood transfusion. When hemoglobin level is less than 6, blood transfusion probably will benefit from the transfusion. Between 6 to 8, transfusion unlikely to be benefit in the absence of bleeding or impending surgery. More than 8, no indication for transfusion unless the surgery is of there is increased risk of bleeding in the surgery. Now, how to calculate allowable blood loss? Hematocrit is considered 45 and the target hematocrit considered is 30 for the transfusion trigger. So mean our allowable blood loss is calculated according to the body weight of the patient, estimated body volume into starting hematocrit minus target hematocrit divided by starting hematocrit. So for the 70 kg normal person, minimum allowable blood loss is around 1633 ml. Now we'll come to the blood products. Blood products are divided into cellular components. It has red cell concentrate, platelet concentrate, and granulocyte concentrate. Plasma components: fresh frozen plasma, cryoprecipitate, cryo-poor plasma, stored plasma. Plasma derivatives: albumin, immunoglobulins, coagulation factors. Appropriate use of blood and blood products. It means the transfusion of safe blood products only to treat a condition leading to significant morbidity or mortality that can be prevented or that cannot be prevented or managed by other means. Rational use of blood and their products is to reduce unnecessary transfusions and minimize the risk of associated with transfusion. The major advance in the field of blood banking has been the development of blood component therapy. Scheme for separation of whole blood for component therapy. It is called as apheresis. Whole blood is centrifuged and packed red cells are removed, which are then freezed at minus 80 degrees Celsius to frozen red cells. Then it is processed to reduce the leukocyte count, and then leukocyte poor red cells are formed. Remaining product is platelet rich plasma, which is again centrifuged at 20 degrees Celsius, and platelets are separated. Platelets then stored at 20 to 25 degrees Celsius. Platelet poor plasma is then again freezed to minus 20 degrees Celsius to create fresh frozen plasma. Fresh frozen plasma is generally separated within 8 hours of donation. Again, platelet poor plasma is freezed at minus 70 degrees Celsius, then thawed to create cryoprecipitate, and the remaining is factor 8 poor plasma. Rationale of blood transfusion: using right blood product, administer at right dose, choosing the right time, and identifying the right reasons. Whole blood. Whole blood is donor blood plus anticoagulant. Anticoagulant use is CPDA, which is generally 49 ml used. 1 unit contains 350 ml, rich in coagulation factors. Hematocrit is 45%. It is stored at 2 to 6 degrees Celsius. Its shelf life is 35 days. Indications for whole blood is acute blood loss with hypovolemia, exchange transfusion, severe anemia at birth, severe hyperbilirubinemia, massive transfusion in trauma or war injuries, cardiovascular bypass surgery. Contraindications are chronic anemia and incipient cardiac failure. In recent years, red cell concentrates is replacing the whole blood because as platelets function is rapidly lost during the whole blood storage, there is no useful platelets function left after 24 hours of cold storage. Other than hemorrhage, most indications of RBCs can be effectively treated with PRBCs, retaining the plasma and other components for the other patients. So nowadays, most of the times it is used when red cell concentrates are not available. PRBCs. packed red cell concentrates without platelets and plasma. 1 unit is 330 ml. Anticoagulant uses SAGM, that is saline adenosine glucose mannitol. Older it was used CAG, citrate phosphate dextrose. Hematocrit of PRBC is around 65 to 75%. It increases HB by 1 gram of DL. Shelf life is 35 days, but nowadays because of the newer SAGM anticoagulant, it can be stored up to 45 days. Storage is 2 to 4 degrees Celsius, increases oxygen carrying capacity of the blood. Special treatment during PRBC storage. The most common side effect of PRBC is febrile reactions due to the leukocytes in the cells. That is, while separating with RBCs, leukocytes are also removed. So because of that, alloimmunization in pregnancy or those patients who are receiving chronic blood transfusions undergo immunization reactions. So leukocytes are removed. So 3 processes are done for that. Leukocytes depletion. Leukocytes in final PRBC should be less than 5 into 10 raised to 8 to prevent febrile reaction. For this, leukocytes filters are used. Saline washing is done. Red cells are washed with sterile normal saline by centrifugation at 2 to 8 degrees Celsius to remove residual plasma and preservatives. And irradiation, it is done using gamma rays at 25 gray to prevent graft versus host disease due to proliferation of lymphocytes. Indications of red cell concentrates: severe anemia less than 7 gram per dl, that is restrictive transfusion strategy. Restrictive RBC transfusion threshold of 8 gram per dl when undergoing orthopedic or cardiac surgery and to those with pre-existing cardiac disease. Trauma with acute blood loss more than 20% of the body weight. Thalassemia, sickle cell anemia. Rational use of PRBC transfusion in OBS and gynec. Normocytic and hypochromic anemia, generally trial of oral iron should be considered. Parenteral iron is an option when oral iron is not tolerated. So generally, blood is not the choice in obstetrics and gynecology. There is no actually firm criteria. Decision should be taken on clinical and hematological correlations. Anemic woman who is not actively bleeding intrapartum or immediate postpartum, HB levels of around 7 gram per dl is indicated for PRBC transfusion. In case of actively bleeding patients, follow massive transfusion protocols. FFP should be used for every unit of RBC in major hemorrhage. Platelet count should be maintained above 50,000 and life-threatening PPH, consider factor 7A transfusion. PRBC in less than 4 months old babies. The babies who are having symptomatic anemia with tachycardia, tachypnea, poor feeding, HB should be maintained above 7 gram per dl. For that, recommendation 10 to 15 ml per kg of PRBCs can be given to the baby. On the infants who are on oxygen, that is cannula, hood, or who has tachycardia, tachypnea, HB should be maintained above 10 gram. On more than 35% oxygen by hood or CPAP, HB should be maintained about 12, and congenital cyanotic heart disease, it should be maintained about 15. In older infants, more than 4 months, intraoperative blood loss, when there is more than 15%, HB should be, PRBC should be transfused to maintain HB above 8 gram per dl. In severe pulmonary disease, it should be more than 13 gram, sickle cell disease more than 10 gram, and acute blood loss with unresponsive hypovolemia, no need of transfusion. In surgical and ortho cases, recommended strategy is restrictive, that is 8 gram per dl. Transfuse if symptomatic anemia, chest pain, tachycardia, responsiveness to fluid resuscitation, orthostatic hypotension, and heart failure is there. Patients who are not actively bleeding should be transfused with single unit of PRBC and then again reassess before further transfusions. For post-operative cardiac surgeries who are not bleeding and cardiovascularly stable, guidelines recommend that only give when HB is less than 7 gram. Transfusion in critically ill patients, hemodynamically stable adult or pediatric patients, transfusion should be given when HB is less than 7. Post-operative surgical patients, when HB is less than 8 gram with symptoms of chest pain, orthostatic hypotension, tachycardia, blood transfusion should be administered. In patients who are hemodynamically stable, there is no much evidence that will benefit after transfusion. Hemodynamically stable patients with acute coronary syndrome, no need of transfusing the PRBC. In thalassemia intermedia and HB thalassemia may not need regular transfusion unless they are symptomatic. And in thalassemia major patient, clinical parameters are the utmost importance to decide. HB less than 7 on 2 successive occasions separated by at least 2 weeks, transfusion should be done. Patient growth, activity, academic performance is hampered, then it should be done. Unnatural bony growth due to marrow expansion, even if HB is between 7 to 10 and above clinical features are present, then transfusion should be done. Platelet concentrates. Platelet rich plasma is separated, either pooled from 4 to 6 whole blood donations, that is RDP, or apheresis concentrates obtained from one single donor. 1 unit is 15 to 20 ml, shelf life is 5 days, storage is 20 to 24 degrees Celsius. Under ideal circumstances, 1 unit of platelet increases count by 7,000 to 10,000 per liter after 1 hour of transfusion. Platelet concentrates can lead to sepsis due to increased chances of bacterial contamination, as they are need to be stored at room temperature. Fever within 6 hours of receiving platelets, sepsis from platelets should be considered. Indications: surgical and obstetric patients with microvascular bleeding, platelet dysfunction causing microvascular bleeding, drug-induced hemorrhage. Contraindications: ITP, TTP, untreated DIC, thrombocytopenia associated with septicemia in cases of hypersplenism. Transfusion trigger for prophylactic platelet, reversible bone marrow failure when there is chances of recovery, then if the platelet count is 10,000, prophylactic platelet transfusion should be performed. In chronic bone marrow failure when there is no recovery, no prophylactic platelet is recommended. Critically ill patients, 10,000 venous central lines for 10,000. For lumbar puncture, it is 40,000. Insertion, removal of epidural catheters, it is 40,000. Major surgery, 40,000. Neurosurgery and ophthalmic surgery is 1 lakh. And percutaneous liver biopsy, 50,000. Renal biopsy, avoid platelet transfusion. Instead, use desmopressin. Transfusion trigger for therapeutic platelet transfusion. Where severe bleeding, there is massive transfusion, platelet count should be maintained above 50,000. Multiple trauma, traumatic brain injury, it should be maintained above 1 lakh. Non-severe bleeding, 30,000 can be permitted. DIC in presence of bleeding, 30,000. Plasma products: fresh frozen plasma, cryoprecipitate, factor 8, factor 9, albumin, prothrombin complex concentrate, antithrombin concentrates, gamma globulins. Fresh frozen plasma, plasma collected from single donor or apheresis and frozen within 8 hours of collection. 1 unit is 200 to 250 ml, contains clotting factors, fibrinogen, antithrombin, protein C and S, albumin and immunoglobulins, stored at -40 to -50 degrees Celsius. Shelf life is 2 years. Indications: first line therapy for coagulative hemorrhage, single clotting factor deficiency, multiple clotting factor deficiency, prevention of dilutional coagulability in massive transfusion, reversal of warfarin anticoagulation when severe bleeding is present, thrombotic thrombocytopenic purpura. Dose of FFP transfused should be 10 to 50 ml per body weight. During massive transfusion, FFP should be given in fixed doses. FFP should not be used in as plasma volume expanders or for nutritional purpose like hypoproteinemia. Should not be used as prophylactic transfusions if INR is less than 1.5, and should not be used in actively bleeding patients with normal coagulation tests. Cryoprecipitate, produced by controlled thawing of FFP, quantity 10 to 20 ml. It contains fibrinogen 150 to 300 mg, factor 8, 80 to 120 mg, 1 milligram factor 80 to 120 units, fibronectin, plasma proteins in only trace amount, storage -30 degrees Celsius, shelf life 2 years. Indication: first choice in DIC, 1 milligram disease and fibrinogen deficiency. Factor 8 concentrate, indications: hemophilia, side effects are allergic reactions and hyperfibrinogenemia after massive doses. Factor 9 concentrate, indication: acute bleeding and perioperatively in Christmas disease, side effects are allergic reactions. Fibrinogen concentrates derived from human plasma and does not contain relevant levels of coagulation factors. Administration of fibrinogen can reduce the required need for allogenic blood components. It demonstrates clear potential to improve hemostasis. Single dose of 4 gram fibrinogen achieves blood level approximately 200 mg per dl. It reduces the incidence of platelet administration and number of donor exposures. albumin and plasma protein derivatives. These solutions are prepared commercially from albumin fractions from large pools of plasma reconstituted in isotonic electrolyte solutions available as 5% and 25% solutions in isotonic saline, uses documented hypoproteinemia, burns, peritonitis, expands vascular space and causes extracellular fluid space depletion. Hence, fluids such as 0.9% saline or RL should be given to expand extracellular fluid space. Autologous blood. Blood is autologous blood, collection of the transfusion of client's own blood. It can be collected weekly up to 3 weeks before surgery and it can be stored. Hematocrit should be around 45%. Storage at 2 to 6 degrees Celsius and shelf life is 35 days. General duration of transfusion in which the specific component should be given. Whole blood or PRBC within it should be started within 30 minutes of removing from refrigerator and it should be completed within 4 hours unless discard remaining whole blood. Platelet concentrate immediately and it should be completed within 30 minutes. FFP carbohydrate same within 30 minutes. Massive blood transfusion. Definition: replacement of one entire blood volume within 24 hours or transfusion of more than 10 units of PRBC in 24 hours, transfusion of 4 units of RBCs in 1 hour or replacement of 50% of total blood volume within 3 to 4 hours. Massive blood transfusion are designed to interrupt lethal triad of acidosis, hypothermia and coagulopathy. Aggressive management of injury associated with it is given for management of injury associated with coagulopathy. PRBC is to FFP is to platelet ratio should be 1:1:1. Negative points are it is the rationale is not standardized. The trigger as well as the ratio of transfusion varies from center to center, and if massive transfusion protocol is triggered for non-massive blood loss, it can lead to wastage of hemostatic and blood replacement therapy. When massive blood transfusion protocol is initiated, initially 4 bags are initially blood tests are sent for CBC, PT, PTT, and 4 PRBCs are administered. After giving 2 PRBCs, again patient vitals are checked. BP, if there is BP less than 70 mm or PT, PTT derange, then with again 2 PRBCs, crystalloids plus FFP and platelets are administered. After that, again, the symptomatically and clinically patient are seen. If the indications are still present, that is BP is less than 90 after 2 BRBC and FFP, then further PRBCs are transfused. After 3 to 4 PRBC transfusion, mainly whole blood can be administered instead of packed cell to maintain hematocrit above 30. Key points in massive transfusion. Activated factor 7, the role is unclear. It can be used as rescue therapy in patients with life-threatening bleeding. Recommended dose is 200 microgram per kg initially. Then 100 microgram at 1 and 3 hours. Antifibrinolytic agents, injection tranexamic acid, 15 mg per kg loading dose over 10 minutes is recommended. It is more useful when given within first 3 hours of hemorrhage. Salvage therapy is extremely helpful in case of rare blood group. Thank you.
Excellent presentation done by Mrunmayee. All the aspects and very much detailed study of blood products were done, and it was really indeed a very excellent lecture.
I request chairperson to felicitate speaker. I request chairperson to be seated for next session also.
Dr. Vaishali More will introduce Dr. Nilesh Bhute.
Okay, next speaker is Dr. Nilesh Bhute. Dr. Nilesh is MBBS diploma in anesthesia and he is consultant anesthesiologist since 2007 and member of Association of Regional Anesthesia since 2015, secretary of ISA Satara in 2018, and his special interest in regional anesthesia mainly upper and lower limb blocks. Dr. Nilesh, please.
Okay. Good evening, everybody. The topic is ultrasound guided upper limb block. First, we will see the anatomy of brachial plexus supplies upper limb. Mainly, it is formed by C5, C6, C7, C8, and T1. If C4 is involved, it is called as prefixed. If T2 is involved, it is called as postfix. Commonly, it is by C5 to T1. These are the roots, C5 to T1. Then it develops trunk, then again divisions, and then lastly chords. So C5, C6 root combines to form upper trunk, C7 forms middle trunk, and C8 T1 forms lower trunk. These trunks again divides into anterior and posterior division. Anterior division of upper trunk and middle trunk, they unites and forms the chords, lateral chord. Then posterior division of all trunks forms medial chord, and middle trunk continue as posterior medial chord. This is the anatomical image where you can see C4 is involved in brachial plexus. So it is called as prefixed brachial plexus. Here you can see C5, C6, C7, C8, T1. If you give block or if you give analgesic drug at this level, it is called as interscalene block. After root, there are chords. If you give injection at chords, it is supraclavicular brachial plexus block. Then at the level of chord, it is infraclavicular or axillary chord. You can see there is subclavian artery, just lateral to subclavian artery, you can give supraclavicular block. So we'll see types of technique. Which type you can give the brachial plexus block. The most common and old method is landmark guided or paresthesia guided, then PNS guided, and then USG guided. We will see one by one. Landmark guided, the old technique, paresthesia method. It is classical approach is see both the ends of clavicle, see midpoint of clavicle. At the 1 centimeter above midpoint, you can prick by needle and ask patient whether he is feeling tingling. If patient says tingling, you can give drug. This is the old classical method. Here patient cooperation is required. But what are the disadvantages? There are injury to nerve and surrounding, intravascular injection. There is chances of failure of block. Patient may say, I have got the tingling sensation, and if you give drug and action will not come. If patient lies, then chances of patchy action, spread of action is less. Then patient cooperation is very much required for landmark guided technique. Suppose patient is obese, you cannot feel the landmark, so you don't know where you are pricking. If patient is unconscious, he cannot say, I got tingling sensation. So in unconscious patient with landmark guided, it is not possible. In pediatric patient will never cooperate for landmark guided block. And it is difficult in anatomical variation. Suppose there is any anatomical variation of brachial plexus, you cannot give block with this landmark technique. Why to go for USG guided block? Why to go for PNS guided block? Surgeon is not going to pay you more if you are giving PNS guided or USG guided block. Patient is not going to pay surgeon, so surgeon will not pay it to you. Then why to go? So we have to see what are the advantages of PNS guided or USG guided block. So advantages are injury to nerve and tissue is less comparatively, less chances of intravascular injection, can be done with sedation or transient intravenous anesthesia. If patient is irritable or unconscious, can be given in pediatric patient. So what are the disadvantages? Instrument cost, it's your investment, and assistant is required. Next is USG guided. What are the advantages? All disadvantages of PNS are minimized. There is high success rate. Disadvantages, machine cost is too much, and it is technically difficult. You cannot carry the machine with you, and you cannot go to multiple hospital with USG. So if you are working in an institute, then only it is possible to give a block in with USG. So can you guess what happened to this X-ray? This patient, this is a huge pneumothorax. This is pneumothorax because of supraclavicular brachial plexus block given with classical approach. This is the case reports in Srinagar, GMC Srinagar. They have shown if you the patient has got the supraclavicular block with classical landmark guided technique. After 5 minutes, patient develops breathlessness. They have done the X-ray. X-ray shows huge, large pneumothorax. What they conclude in this case report, see the use of ultrasound guided technique in place of classical approach to the brachial plexus block is highly recommended as it is associated with reduced complication rate. So again, next study is comparative study between nerve stimulator guided technique and ultrasound guided technique of supraclavicular nerve block for upper limb surgery. It is done in Rajasthan. What they say, the duration of sensory and motor block was 7 hours and 6 hours for group of PNS. Comparatively 8 hours and 7 hours respectively in group of USG guided block. So both are more in USG guided block. Success rate was 90% in PNS guided, while 97.5% in ultrasound guided block. So conclusion is ultrasound guided is more significantly better than PNS guided. It's another study, same, it shows comparison between USG and PNS. What they say, time required for procedure in minutes, 22 minutes for PNS. Surgeon 22 मिनिटं बोर होऊन जातील. What 15 minutes in USG, so 15 minutes is comparatively less, so surgeon will be happy. 15 minutes 15 मिनिटात block दिला. Next is onset of sensory block in minutes is 23 minutes in PNS, while 15 minutes in USG. Again, scrubbing and all these things takes 15 minutes, so it's okay, USG with 15 minutes. Onset of motor block is also faster in USG, that is 19 minutes, here it is 28 minutes. Block duration is hours. Suppose any surgeon is slow, so he will be happy. You are given USG guided, I can do surgery for more than 4-5 hours. So 10 hours for USG block duration and 6 hours for PNS guided. Post-operative analgesia is 8 hours. Here it is 5 hours. Rate of success is both in methods is 100%. So incidence of complication is 0. This is more important. Incidence with PNS and USG, it is 0. Here another study, comparatively study. It is also same procedure time, onset of sensory block, motor block. Everything is faster in USG guided block comparative to PNS guided block. Duration of motor block is also important, which is more in USG guided block 6 hours. Here it is 5 hours in PNS guided. So we'll see, we have seen the USG, how USG guided block is more advantageous than PNS guided. No question of landmark guided block, it is outdated now. Though all freelancers are giving with landmark guided, but with updation, USG is must. So we will see sonoanatomy of brachial plexus. This is the probe position. Can you see this? This probe position in the midline. This is a high frequency linear probe, which is 10 to 15 hertz frequency. You can place this in midline. Can you see this in corner, right corner? So in midline you can see ear mucosal interface, then cricoid cartilage, cricothyroid junction. Laterally you can see right lobe of thyroid and left lobe of thyroid. Carotid artery also seen. As you go laterally from midline, you can see thyroid gland, carotid artery, internal jugular vein, and longus colymus. Again, from subclavian artery, internal jugular, go laterally, you can see both the scalene muscles, scalenus anterior and scalenus medius. And in between these two, you can see the brachial plexus. It is traffic signal sign. You can see like traffic signal, all four roots you can be seen. Below this there is vertebral artery. In color Doppler you can see vertebral artery, so you cannot give drug intravascularly. Above the scalenus anterior muscle there is phrenic nerve, so you can see your needle away from phrenic nerve, so chances of diaphragmatic paralysis is very less. Where if a patient came with fractured ribs and diaphragmatic paralysis of another side, and you are giving block on normal diaphragm, if you give drug towards phrenic nerve, then both diaphragm will be paralyzed, so patient will become apneic or dyspneic. So it is important to see phrenic nerve and then give block. As you have seen, interscalene groove go downwards. The probe should move downwards. As you can see on right corner of slide, the probe moved to downwards. You can see the bunch of grapes. These are the supraclavicular plexus, in which there is upper, middle and lower cord is there, or superior, middle and inferior cord is there. Medially there is subclavian artery. Again medially internal jugular vein. Below internal jugular vein you can see the medial part of pleura. Just lateral to the pleura there is first rib. You can see this. Then there is acoustic shadow of first rib. Then again laterally you can see lateral pleura. Okay. And this bunch of grapes is brachial plexus. So I was given the block that is interscalene block. So you can see the needle. Needle is placed in, this is traffic signal sign 1, 2, 3, and needle is placed in between. So you can drug here, you can deposit drug here. So here needle in supraclavicular plexus. These are the plexus, like bunch of grapes, and this is the needle. So my needle point is towards the posterior cord. So this is the live demonstration interscalene video. You can see I have placed the needle. See how after giving drug how it appears. See, the drug is given, so all the plexus are floating. Can you see this? So all the roots are there in the floating in the fluid drug. This supraclavicular video, you can see. Here is the needle, and here is the bunch of grapes. So these are brachial plexus. You can confirm it with the help of nerve locator also, PNS guided. So I have used USG plus PNS. So you can see, you can confirm your needle in place by seeing the twitches. Can you see these twitches? Yes. So we can confirm with both the methods. Needle probe with 0.3 milliampere twitches are there. So I have confirmed with PNS. Then I have given the drug. You can see this is the needle. These are the brachial plexus. You can see drug deposition here, and all the bunch of grapes like appearance of brachial plexus will float in the drug. You can notice here that after giving drug, you can notice the drug is there. Can you see this? So drug is now totally around the brachial plexus. Here is your pleura, this is rib. See, drug is there. Only 10 ml drug is given. 10 ml drug is sufficient for supraclavicular block. This is pleura, this one is first rib. So you can give 10 ml for interscalene, 10 ml for supraclavicular blocks. Only 10 ml you can use. So what is the advantage of minimal drug? So you can give, if patient came with creatinine in 4, 5, 6, so you can give 10 ml of drug is sufficient for this patient. So my next topic, after my lecture, there is lecture by Dr. Amruta on toxicity of drug. She will explain why dose of drug is important. So this is after giving block, we have done the humerus nailing. It's a short video. The patient is absolutely pain-free, sleeping nicely, old person. This supraclavicular patient. So we have first done volar button. We are fixed. Afterwards, anteriorly, we have opened the fracture to reduce the fragment. Pulse BP is absolutely stable. Patient is totally comfortable. Another use of ultrasonography is pain, for pain clinic. So one patient, young lady, 26 years old, came with Raynaud disease with very much pain in little finger only. She cannot, last 3 days she cannot sleep. So I have given the only isolated ulnar nerve block. After pain relief, she is very much happy with this. You can see the video. This is ulnar artery and this is the ulnar nerve, honeycomb appearance. So I have given here isolated ulnar nerve block. I have given anavin 0.5% 10 ml with nalbuphine. So can you see the drug? See this. 10 ml of drug is sufficient for this patient. So she became very much happy with 100% pain relief for minimum 6 days. After 6 days again pain appears. Then I referred patient to Pune. They have given stellate ganglion block, radio ablation, and with radio ablation again they have given ulnar nerve block. So now she is pain free. This is added advantage of USG. You can use it in pain clinic with isolated nerve block. So in conclusion, in USG guided block is early onset of motor and sensory block, is longer duration of action, high success rate 99% compared to 97% of PNS, less traumatic to nerves and surrounding structure, less chances of intravascular injection, dose required is less, so useful in renal compromised patient. Thank you.
I ask some questions if
Yes,
you don't
why not?
mind.
Why not?
One thing, you please highlight what is the difference of volume when you are giving by landmark method, by PNS method and by USG method.
Okay.
Second thing, I would like to ask what local anesthetics exactly you are using for the blocks.
Okay.
And third thing, I would like to ask what is the management if there is local anesthesia toxicity.
Okay. First is volume. How much volume is required? So minimal 10 ml you can give with USG guided block. With landmark technique we used to give 30 ml of drugs. But for USG guided minimal 10 ml is sufficient. For interscalene some people give only 5 ml. I have never given 5 ml. I used to give 10 ml. Second thing, which drug? Second question. So I usually use 0.75% ropin plus injection xylocaine with adrenaline, and mixture of it I usually give. Third question, what happen if you intravascular injection of drug? So I think my next topic is same. So she will answer better than me. Intralipid is a treatment, and convulsion if occurs, anticonvulsant and treatment of convulsion is important. So airway and all these things. Okay, thank you.
Yes, excellent presentation.
Thank you.
What are the orthopedic indications for this technique? In which orthopedic surgeries can you use this technique?
I'm routinely using
I want to ask because it is a USG guided.
Yes.
So what is its use for the common orthopedic surgeon if you are going in the medium sized setups?
Okay.
Or one question. Second, whether it is having any medico legal issue. I mean, if you are giving block and that block fails, and if this facility is available, that USG guided, if it is failing, why you have not used this technique? if it is available. And if it is not, you say, if it is not available in this setup, then they may say that you might have take this case to another setup or something like that. So what
Okay.
is your opinion on that?
First thing is USG machine is required. So it is only done in multi-specialty hospital, because you can use in individual setup, but you have to purchase the machine. Second thing, in all upper limb surgeries, you can use USG guided block. Brachial plexus supplies all upper limb. So from fracture humerus head to radius ulnar distal metacarpal fracture, all metacarpal and carpal fracture, all surgeries you can use USG guided block. Second thing, medico-legal implication, success rate is 99% with USG guided and 97% in PNS. So if USG is available and you are not trained in USG, nothing to worry, you can give with PNS, no medico-legal issues. But suppose some complications happens, to avoid the complication, you can use PNS. So medical legal issue, if you use landmark guided and if you USG guided, then medical legal issue is there. Should not use with use landmark guided techniques. If suppose nerve injury occurs, then legal issues can come. Why you are not use PNS? Why you are not use USG? These are the issues.
Thank you, Dr. Nilesh.
Thank you.
About getting the permission from the government officers for USG machine and carrying a USG machine by anesthetist.
Okay. First thing, you cannot carry USG machine. It's not allowed in India.
Important, yeah, that's.
Second thing, permission is not an issue. You are using linear probe, so which is not used for abdomen. So for upper limb surgeries, you use linear probe, so no issue with permission. For lower limb surgery, definitely yes, you have to register to your concerned authorities, and you have to say you are not doing USG abdomen at all. You have to register each and every case to civil. But for upper limb, linear probe, no issue.
Hello. Thank you, Nilesh,
Thank you very much.
for the excellent talk on this USG guided blocks. We should upgrade ourselves with time. This is the message from your lecture. I request Shashi Patil Madam to felicitate Dr. Nilesh Bhute for his excellent talk on this topic. Photo. I request Mugdha Mahajan to felicitate Shashi Patil Madam. I request Neha Fattare, Dr. Neha Fattare to felicitate Dr. Vaishali More. Thank you both the chairpersons. I request Gosavi sir to chair next session. I request Dr. Parimal for the next chairperson. The next lecture is of Dr. Amruta Bokil on toxicity of local anesthetics. Parimal will introduce Dr. Amruta Bokil.
Next speaker is Dr. Amruta Hippalgaonkar Bokil. She has done MBBS, MD and DNB anesthesiology from Sion Hospital, Mumbai. She also has done fellowship in pain management from Sir Gangaram Hospital, New Delhi. She is assistant professor, Government Cancer Hospital, Aurangabad for 2014-15. Then she has worked in LTMMC Sion from 2015 to 17. And in KIMS Karad, she is working since 2018. She is working as consultant anesthesiologist in Satara since 2017. She has got publications, 9 case papers and 3 original articles. So may I request Dr. Amruta Bokil to deliver her lecture, please.
Thank you, sir, for such a kind intro. Good evening, one and all, and welcome to this session. I'm going to speak about local anesthesia toxicity. We have seen a beautiful lecture now about the USG guided blocks, a beautiful side of anesthesia. Now we will go to the darker side, that is local anesthesia toxicity. Local anesthetics are used day in and day out by everybody, most of the clinicians. Points to ponder about this is most cases of local anesthesia toxicity occur in clinics, outpatient OPD basis, or outpatient surgical centers. Most of them anesthetics which provoke the potent toxic reactions are often injected or provided by non-anesthesiologists or in absence of anesthesiologists. And this leads to misdiagnosis and underreporting of the LA associated complications. A brief introduction about what is a local anesthetic and what is the structure. Local anesthetic has every local anesthetic molecule has two domains, a hydrophilic and a lipophilic domain, which are connected either by an ester or an amide linkage. Now, greater the lipid solubility, greater is the potency of the drug and larger is the duration of action. But mind you, that increase in potency comes with increased toxicity and decreased therapeutic index. We'll see the amino esterase and amino amides. The amino esterases are procaine, chloroprocaine, tetracaine, benzocaine, cocaine, which are metabolized by pseudocholine esterases in the pseudocholine esterases, except the cocaine, which is metabolized in the liver. Usually nowadays, amino esterases are not used. We are more focusing on amino amides, the lignocaine, bupivacaine, ropivacaine, mepivacaine. Amongst them, the lignocaine, bupivacaine, ropivacaine are the most commonly used, metabolized in the liver. Classification according to duration of action: short acting, that is procaine, chloroprocaine is the shortest acting. Intermediate comes the lignocaine of interest, and long acting is bupivacaine, levobupivacaine, ropivacaine, and dibucaine is longest acting. What are the risk factors related to toxicity? We'll see what is the drug profile related to drug. That is the type of LA used. Long acting drugs will cause more toxicity. The dose of drug, when we are using larger concentration, larger volume of drug, it may result in toxicity. Now the block related, the site of administration. When we administer a block near a more vascular region, for example, in the intercostal nerve blocks, they are more prone as compared to brachial plexus, as compared to epidurals. Single or continuous administration of a block will result in continuous pooling of the local anesthetic in the region, region, and hence increasing the systemic absorption. And conduct of block is very important. That is whether we are taking all the precautions, we are aspirating the needle or the catheter just before the injection. And condition of the patient. Patient with pre-existing renal, liver, cardiac disease are more prone to. Similarly, pregnancy, elderly patients, and pediatric patients are more prone to toxicity. This slide shows that addition of a vasoconstrictor like epinephrine, it decreases the vascular uptake of the local anesthetic and thus increases the safety dose for the drug. So the lidocaine of interest, it is 5 milligram, 4.5 to 5 milligram per kg can be used as a plain solution. But when we use local lignocaine plus adrenaline, then we can use up to 7 milligram per kg. Similarly with bupivacaine, 2 milligram per kg, and when we use with epinephrine, you can use up to 3 milligram per kg. Now toxic reactions, thus they occur due to accidental intravascular, which is the most common cause, then by intrathecal injection or by unwanted excessive administration of a drug. True allergic reactions, they are very rare, mainly because of esters, which are not nowadays used because of the para-aminobenzoic acid which is contained in them, and sometimes in amide because of the methylparaben which is used as a preservative. They present as rashes, urticaria, or some may present with full-blown anaphylaxis, and treatment is accordingly. Coming to the main topic, that is systemic toxicity, they can affect the neurological, cardiovascular, hematological, hepatic system, and local tissue toxicity. Local anesthesia systemic toxicity, last, which is referred to, is because of the excess plasma concentration of the drug. Now, blockade of voltage-gated sodium channel affects the action potential propagation throughout the body, and therefore it presents as a potential for systemic toxicity. Now, we have to remember that local anesthesia manifestation, toxicity manifestations, they appear usually between 1 to 5 minutes of the injection, but may appear as less as 30 seconds to as long as 90 minutes, even 60 minutes after even the administration of the drug. Neurologically, the LA that is systemically absorbed, it first acts on the inhibitory neurons, and hence the excitatory neurons are stimulated, and hence we first get seizures, and that is followed when the concentration increases by inhibition. So the first sign what we get is some uneasiness in the patient, restlessness, circumoral numbness, tongue paresthesia, tinnitus, and followed by muscular spasm, tonic-clonic seizures, which will result in respiratory arrest and eventually cardiovascular arrest. So this we can see: drowsiness, paresthesia, tinnitus, muscular spasm, seizures, coma, arrest. Now, seizures, what they will do is hypoxia, hypercarbia, respiratory depression. This will in turn increase the respiratory acidosis, increase cerebral blood flow, which increases the active, that is the ionic form of the local anesthetic, which in turn potentiates the toxicity. So we have to halt the seizures as a primary thing. This slide shows the concentrations and how it affects the various nervous systems. One thing we have to see is that the concentration of plasma concentration of the drug which causes the CNS symptoms is around 5 to 10, and almost 3 times the concentration is required for a cardiovascular collapse. Coming to cardiotoxicity, they inhibit the voltage-gated sodium channels, calcium channels, and they cause conduction disturbances, contractile dysfunction, and ventricular arrhythmias. Initially, there is an excitatory effect leading to hypertension and tachycardia, followed by a negative inotropic effect on the conduction system, resulting in increased PR interval, duration of QRS complex, arrest, and finally complete heart block. All these local anesthetics except levobupivacaine and ropivacaine, which have an intrinsic vasoconstrictor action, all the others, they will cause vasodilation, bradycardia, and hypotension. Major cardiovascular toxicity, as we have already learned, that it comes from 3 times that of the blood concentration which is required to cause the seizures. But when we give blocks, we usually sedate a patient. So benzodiazepines, when we give it, helps in the it decreases the manifestation of seizures, and hence under general anesthesia, cardiac collapse may be the only presenting symptom. Now, why we are more concerned about the toxicity due to bupivacaine? Because it has a fast in and slow out principle. Means what? It binds to the sodium channels fast, but the release from the sodium channels in the diastole is very, very slow. Hence, we require a large amount of patience and prolonged resuscitation. While against this, the lignocaine has a fast in and fast out principle. A newly formed molecule, now we have more moving towards this pure S enantiomer, that is ropivacaine. It has a low lipid solubility, easy reversibility, low affinity for cardiac sodium channels. So it has a higher threshold for both CNS and CVS toxicity. So hence it has an improved safety profile. Now, coming to local tissue toxicity, quada equina syndrome, it is mainly because of the pooling of drug around the quada equina, usually diffuse injury in the lumbosacral plexus, but it results in permanent neurological damage, and patient presents with sensory anesthesia, paraplegia, bowel and bladder dysfunction. Mainly it occurs because of lidocaine, then followed by bupivacaine and ropivacaine. Transient neurological symptom, this is the main reason why lidocaine spinal anesthesia was withdrawn from the market. It is dysesthesia, moderate to severe burning, aching pain in the lower back, posterior thighs, buttocks. It usually appears 6 to 36 hours after complete recovery from a single shot uneventful spinal anesthesia. Attributed to radical irritation, it is shown that there is no neurological permanent damage in this group of symptoms and usually resolves within a week. Lidocaine intrathecal has a potency of about as high as 30% to cause this transient neurological symptoms. Methemoglobinemia, it is mainly because of the prelocaine. Usually prelocaine is used as a eutectic mixture, mainly known as an EMLA mixture for surface anesthesia. Mainly it doesn't cause any problems in adult patients, but in pediatric patients and elderly patients, what it does is it is metabolized in the liver to orthotoluidine, which oxidizes hemoglobin to methemoglobin. 1 to 3% of methemoglobinemia is also not an issue. It is asymptomatic, but as the concentration of it increases, it will cause all the symptoms of fatigue, cyanosis, and everything. But it is readily reversed by methylene blue, 1 to 2 milligram intravenously, and hyperbaric oxygen. What methylene blue does is it non-enzymatically converts the methemoglobin to hemoglobin and acts as an electron donor. Musculoskeletal toxicity causes myonecrosis if it directly is injected into the muscle. More so it is worsened when we use a steroid and epinephrine. Regeneration usually takes within 3 to 4 weeks. Ropivacaine has less tendency of all these toxic reactions. Now, if at all the signs and symptoms of last occur, what we should do? First and foremost thing is early recognition with high vigilance and suspicion. Stop injecting the LA if you're still doing it. Call for help, leaving behind all our attitudes, egos, because it is a team effort and requires more people to help us. And as we have seen in the Caesar slide, that airway management is more important because the more hypoxia, more acidosis, more potentiation of the toxicity. For seizures, the ASTRA recommends benzodiazepines as the first line of drugs. If they are not available, then you can go with propofol or thiopentone, but propofol has to be given in very minute doses, 1 milligram, less than 1 milligram per kg, about 20 to 30 milligram aliquots, because it causes cardiodepression and hypotension and thus potentiates toxicity. And if the seizures still persist, you can go with a muscle relaxant short acting, that is succinylcholine, small doses. Cardiac dysrhythmias progressing to cardiac arrest, we have to follow the standard advanced cardiac life support guidelines with a minor modifications. They are, epinephrine has to be used, but it has to be used in doses of less than or equal to 1 microgram per kg, because it unnecessarily increases the afterload and thus acts on the causes the heart to act more in the weakened heart. Also, vasopressin, calcium channel blockers and beta blockers, because of their cardiodepressant effects, they have to be avoided. If ventricular arrhythmias develop, instead of going for lidocaine and class 1 antiarrhythmics, we have to prefer amiodarone. And if none of this works, you have to go with cardiac pacing and cardiopulmonary bypass. So the slide shows what are the initial management and emergency call: stop LA injection, secure airway, establish an IV line. Mostly in the OPD basis or outpatient surgical patients, you have to establish an IV line, anticonvulsant, and consider lipid emulsion therapy early. Now coming to lipid emulsion is 20% intralipid. It is 20%, mind you. The mechanism is that it acts by lipid sink hypothesis. That is, it extracts the hydrophobic or the lipid soluble local anesthetics from within the cardiac tissue, thereby improving cardiac conduction, contractility, and perfusion. The dose in less than 70 kgs, you have to give 1.5 ml per kg bolus over a minute, followed by continuous infusion of 0.25 to 0.5 ml per kg per minute. Repeat bolus once or twice for persistent collapse. You can use up to 10 to 12 ml per kg of this lipid solution in the first 30 minutes. And you have to continue infusion for at least 10 minutes, even after attaining the circular stability. Now, this is the lipid solution bottles which have to be kept ready when you are giving blocks or local anesthesia. It comes with various brands and the cost is not more than 700 ml for a 250 ml bottle. Propofol is never a substitute for lipid emulsion because it is only 10%. It causes a cardiodepressant effect, and hundreds of mLs of propofol will be required for resuscitation. And failure to respond to all this therapy is prompt institution of cardiopulmonary bypass. Recommendations for preventing. We have seen how we can treat it now, but we can prevent it by simple small measures. No single measure can prevent it. Maintain vigilance and high suspicion at all times. Now there is no shortcut to obtaining an adequate history, physical examination, identifying risk factors, allergies, anesthetic reactions. Informed written consent of the patient at all stages. Vital sign monitoring including ECG, pulse ox and BP at all times. One thing is that you have to describe the patients the symptoms of local anesthesia overdose. Instruct him that he should inform the physician. Be sure that he understands what you have told him, and emphasize that he should always tell the physician if some of these symptoms are occurring. Know the toxic dose of the local anesthetic you are injecting. One thing you can do is use the lowest effective dose. That is, you can use large volume but in lower concentration of the drug. Use incremental injection in 3 to 5 ml aliquots, pause for 15 seconds and then inject. Then aspirate the needle or catheter before each injection. And maintain verbal contact with the patient during the procedure to even detect the smallest or subtle signs of LA toxicity. And it is very, very important to keep ready all the emergency drugs, airway equipment, oxygen and intralipid at all times in the area where you are giving local anesthetics. Now, when injecting potentially toxic doses, it is recommended that you can use an intravascular marker like epinephrine, because it increases even 10 to 15 microgram per ml of epinephrine. It increases the heart rate by 10 and a systolic blood pressure by 15 millimeters of Hg, and has a sensitivity of 80%. They nowadays say that ultrasound guidance may reduce the frequency, but actual reports are unproven. Documentation is very important, which all of us lack. The amount, the type, the patient, the timing of injection is very, very, very important. Now, the last slide, to sum up the local anesthesia toxicity, what we have seen just now is call for help, keep intralipid ready, then if seizures are there, prevention, treat them with benzodiazepines as a first choice. If not, by propofol, small doses. Then if cardiac arrest ensues, go with standard ACLS guidelines, and consider in lipid emulsion early. Now, when you are using lipid emulsion, at all times you have to keep the CPCR going on. The cardiac chest compressions should go on, because the coronary perfusion is very important. Unless and until the drug reaches the coronaries, it cannot extract the local anesthetic from the heart, and thus cannot decrease the toxicity. So the safety starts with us, not with you. Everybody has to be vigilant about the local anesthesia toxicity. Thank you very much for the patient listening.
Is not available, then what?
Ideally, it should be available whenever you are giving a block, or otherwise you have to continue with the CPCR guidelines, ACLS guidelines, and go for cardiopulmonary bypass.
There is no any other options.
Still, there is no other alternative for intralipid, which is given in ASTA guidelines.
Is it available in Satara?
Yes, sir.
Okay.
Very much. Fresenius Cabi is the brand.
Freshness Cabis.
Yes, yes.
Thank you.
Yes.
I request Dr. Chaitali Jathar to felicitate Dr. Amruta Bokil for her excellent talk. I request Dr. Gosavi sir to introduce Dr. Vasudha Jadhav ma'am for her recorded lecture.
Good evening. Next speaker is talking on the pain clinic. Professor Vasudha Jadhav ma'am, MBBS MD, fellowship in international pain medicine, fellowship in clinical rheumatology, fellowship in cancer carping and palliative care, and short fellowship in musculoskeletal ultrasound and fellowship in critical care, short fellowship in intravenous in nutritional therapy, fellowship in diabetology, ongoing. Now I request Madam Jadhav Madam to continue her oration. Thank you.
Good morning, dear friends. First of all, let me thank ISA Satara and IMA Satara colleagues for giving me this opportunity to speak. Today's my topic is Introduction to Pain Clinic. Pain clinic or pain management is a newer modality nowadays. Even the course of DM is available on pain medicine. We all know all the happiness man can gain is not in pleasure but in rest from pain. So what is a pain clinic? It is a clinic or it is a center where all chronic pain patients are treated. Okay, so who can be pain physicians? Doctors from anesthesia background or from orthopedic background or from medicine or neurology background or from palliative care medicine background can become pain physicians. So what is chronic pain? Any pain which is more than 3 months is considered as chronic pain. And what types of chronic pain patients need treatment and why? Chronic pain patients whose pain cannot be treated by regular measures like medicines or physiotherapy, those daily work is affected because of chronic pain. They are to be treated in the pain clinics. We all know that routinely pain management is done by using medicines, by physical therapy, by lifestyle modifications or pain management, and extra what is here in pain clinics is the nerve blocks. So what is the principle of pain management? After the proper diagnosis, you have to first treat the underlying basic pathology, and then the treatment is done by using of drugs, by different techniques like PRP, prolotherapy, hydrotenolysis or hydrodilatation, and nerve blocks. So what are the advantages of interventional pain block, which is the specialty of pain clinics or pain centers? Surgery is avoided, it is minimally invasive, short hospital stay, it is done under local anesthesia, there is targeted delivery of drugs at the specific areas, early and effective rehabilitation, and there is decreased need for the analgesics. So this is a picture showing the conditions which are treated in pain clinic, right from head to toe, like headaches, neck pain, to ankle sprain, calf pain or plantar fasciitis. How different is the treatment in pain clinics? Basically, the pain clinic focuses on interventional therapy. That means various type of nerve blocks. They are either C-arm guided, CT guided, sonography guided or blind techniques. Then there is another thing, that is prolotherapy. Then there is PRP therapy, that means platelet rich plasma therapy. Then there is use of high-end machines called radiofrequency ablation machines. Then using chemicals and causing neurolysis. And then ultimately the modality which is very costly in our country, that is spinal cord stimulations. So if we start from headaches, you know there are various types of headaches. So supposing in migraine, we all know that the neurologists treat, even the medicine people treat, but what is different in pain clinics is use of Botox in the various small facial muscles. So these the doses are fixed and they are given at a different points. There are definitive points on which this Botox is given. Then if the diagnosis is confirmed, in case of cluster headache, you give sphenopalatine ganglion block. It can be given nasally or it can be given C-arm guided. Radiofrequency ablation is the last treatment in it. Then supraorbital neuralgia. This is very common. I have done almost 15-16 cases of supraorbital neuralgia and I had written an article in it. If on Google, you Google with supraorbital neuralgia, a case report, Dr. Vasudha Jadhav, the first article will come on it is mine. It is the most cited article on Google. Okay. Then another is occipital neuralgia. Here you give nerve block at the back of the neck. Many times headache patients, they are not properly diagnosed. The patient might be having occipital neuralgia and it is diagnosed as just plain headache. So you have to examine, you have to make a diagnosis and you have to give the block. Then trigeminal neuralgia, we all know. There is a different type of treatment in when all the three nerves are involved, V1, V2, V3, and if individual nerve is involved. If all the three are involved, then you have to go for Gasserian ganglion nerve block, that is radiofrequency ablation. And if individual nerve block is involved like mandibular or maxillary, then you can give individual nerve blocks, peripherally. Then in the neck, cervical spondylosis, that we all know. But what is the pain generation or what is the pain generators, that you have to identify, and then you have to block accordingly. Whether the cervical spine, whether the cervical disc or the cervical facets, who are at fault, that we have to identify and we have to give. Commonly what is given at our level of periphery, we think is cervical epidural, but there are cervical transforaminal blocks also. Then another block which is given is stellate ganglion block. It is a sympathetic type of block. Here it is one of the riskiest type of block. Here all the major vessels like carotid or vertebral artery is there. You have to retract them back, and at the C6 level of Chagas tubercle you have to give that block. And the complications, if occur, they are deadly complications. But it is a very commonly type of block. I have given many stellate ganglion blocks for various reasons, like post-herpetic neuralgia. Then in case of Raynaud syndrome, in Raynaud syndrome it has wonderful results. It causes vasodilatation of the affected fingers. Then few of my patients were operated for a CA breast, and they had pain in chest as well as they had pain in the axilla. So in that case I had combined SAP block along with the this stellate ganglion block. It had wonderful results. Then comes the shoulder, frozen shoulder or adhesive capsulitis. We all know that the orthopedicians, here the orthopedicians must be there, they must be knowing that there is a shoulder manipulation. But nowadays if you do hydrodilatation using either normal saline or using dextrose, and it has wonderful results. It releases all the adhesions, and then along with it, if there is a severe pain, then you can give suprascapular nerve block. It gives another good results. And most of the people, if it is extended pain is there, then they also give cervical epidural in such cases, and then do shoulder manipulation and advise exercises accordingly. But hydrodilatation, I prefer hydrodilatation along with suprascapular nerve block. This is another block, 3-in-1 block for shoulder. It is for shoulder arthritis as well as frozen shoulder. Then trigger finger. The patients might be having a trigger finger that we can identify. Most of my orthopedician colleagues will come to know, will already be knowing about this. So you just have to give locally steroid along with the local anesthetic. Then there are nerve entrapments of hand like decurvance. Again here the role of local anesthetic along with steroid is there, or even in carpal tunnel syndrome also. Then lateral epicondylitis, we already know that we give steroids, but what is nowadays latest is giving PRP there. It has wonderful results. Then intercostal neuralgia, especially in case of post-herpetic neuralgia. I give intercostal nerve block for intercostal neuralgia, but in one case the patient's lesions were just 1 month old. So I had tried paravertebral block and it had a wonderful results. Then CRPS and Berger's disease. Here we all know that many injuries can cause CRPS. Post surgery there can be CRPS, or if Berger's disease is there, there is blackening of the fingers. In that case, sympathetic block gives wonderful results. It causes vasodilatation as well as it causes pain relief. Then low back pain, as we already know. You have to first identify, as in the cervical region, you have to identify the pain generator. You have to identify whether the spine is causing pain, whether the disc is causing pain. Disc can be prolapsed intervertebral disc, or it can be IDD, or whether the facet is causing pain, whether there is effusion of the facet joints, whether there is SI joint involvement, or whether there is coccydynia. Accordingly, you have to treat the back pain. So here are some examples like transforaminal for if there is radiation. Commonly people call it sciatica. Then there is a facetal arthropathy for which you give facetal joint block. Along with it, you can give median branch block. That is the therapeutic block for facetal arthropathy. Then for SI joint, you give SI joint block. This is my picture showing lumbar transforaminal block. This is the picture. Then this is SI joint block. Then hip joint pain. For hip joint pain, you have to give genicular nerve block, which is commonly given. Even in case of early cases of avian, you can combine this genicular nerve block for pain relief. Then scar pain. Many of my patients, one of them was a film star. He had was operated for cholecystectomy. He had severe pain. Even he could not wear the clothes. So I did his hydrolysis of the hydrotenolysis of the scar under sonography. So it had wonderful results using tricot and local anesthetic. Then caudal procedures. As we all know, in failed back surgery syndrome or post spinal pain syndrome, which is now called, there is severe pain in the patients in spite of being operated for spine surgeries. In those cases, you have to go caudally. You have to pass a catheter which is called Rags catheter. You have to do adhesiolysis using various solutions, and then in a series you have to do that procedure, and then patient gets pain relief. Then coccydynia. Coccydynia, commonly you all orthopedician must be knowing that local anesthetic along with steroid gives good results, but ganglion impar block, which is a sympathetic block, it gives permanent and better results in coccydynia. A diagram showing ganglion impar block. Then this is my picture showing hydrodissection for inguinodynia. The patient was operated for prostate, and also he had bilateral inguinal hernia. So he had severe inguinodynia. I had done hydrodissection under sonography, and the patient was totally relieved. So then there is painful heel, plantar fasciitis. What we commonly do is we give steroids, but PRP, platelet-rich plasma, gives very good results, and nowadays that is the latest treatment. So platelet-rich plasma, you must be knowing that we have to withdraw blood, then you have to centrifugate, and then we have to separate platelet-rich fluid, and then we have to inject it. So that is very good for shoulder injuries, especially rotator cuff injuries. Then this is a picture showing under sonography guided. I had done 15 cases of supraspinatus tear. Of course, it should be a partial tear and not a complete one. Partial tear gives very good results. After 1 month interval sonography, you can check and see whether it has healed or not. 3 injections are more than enough for total cure. And then you have to advise the physiotherapy to the patients. Then shoulder joint PRP. It is also very good. Intra-articular PRP along with viscose supplement for shoulder joint OA, osteoarthritis. Even bicipital tendinitis, it is a common condition where you can inject PRP. Then OA knee. Osteoarthritis of knee, it is the latest thing where you give platelet-rich plasma along with viscose supplement, and you give genicular nerve block. There are 2-3 conditions where you can do it. If the patient is having grade 4 osteoarthritis and they don't want to go for surgery permanently, then you can go for genicular nerve block along with PRP. Or if a patient has a waiting period for say 1 year or 8-9 months, that time also you can do PRP along with genicular nerve block. That gives pain relief for the patient for 8-9 months. This is a picture showing genicular nerve block. Then another modality is prolotherapy. This is mainly useful in case of ligamental injury or musculoskeletal injuries, where there are multiple points and where you inject a irritant solution like dextrose along with local anesthetic. You don't have to use steroid here because dextrose and local anesthetic both are compatible with each other, and dextrose causes irritation of that area and it causes regeneration because it induces inflammation and it induces the neovascularization of that area, which causes regeneration. I had used 4 or 5 times this process for many conditions, but I had very good result in muscle herniation of knee. Then dry needling. This all even physiotherapists do dry needling, but what is difference here is we do it sonography guided, USG guided. We see the taut points and we do the dry needling. Like if you give transforaminal epidural steroid injection and then you call after 1 month patient for follow-up and then you see the taut needles in USG, then you can do dry needling. Just doing that dry needling will solve the problem. The residual, whatever residual pain is there, that will also go. but you have to do it very judiciously. This is another example of prolotherapy. Then trigger point injections. This is very important, especially in case of fibromyalgia. First of all, you have to identify that this is fibromyalgia. There are 18 points according to ACR guidelines. You have to identify that this is fibromyalgia, and then the most painful points, trigger point injection is given. Just using local anesthetic also it will solve the problem. Then this is just a picture showing a robotic arm. With the use of this, you are more specific in giving the blocks. So there are advanced interventions like spinal cord stimulation, intrathecal drug delivery, which is mainly used in case of malignancy. This is a picture showing it. This is RF ablation machine which I am commonly using. This is the obturator now block for malignancy. 2-3 cases I have done with this. In rheumatological pain, there is inflammation of the joints. Okay, so we use anti-inflammatory agents. We use DMRDs, disease modifying agents. Then we use biologicals. Then here you can use intervention like ankylosing spondylosis. You can use SI joint block. For effusions of joint, you can just reduce the effusions by draining it out, and you can also inject steroids in that. Then in case of scleroderma, you can give stellate ganglion block, which will help in vasodilatation. So the pain management therapy or this chronic pain management is very effective in rheumatological conditions also. But you have to have orientation of rheumatology for that matter. In case of malignancies, there are many interventional blocks. Like in CA ovary, you can give superior hypogastric plexus block. In case of CA pancreas, you give celiac ganglion block. But in case, there was one case of CA buccal mucosa. He came to me with, it was an advanced case. He had multiple metastasis. He was already on morphine. I had just adjusted the dose of morphine. But then here one therapy which actually I did fellowship in was IV nutritional therapy. It helped a lot to that patient. The patient was very in a bad shape when he came to me. I started him IV vitamin C high dose up to 50 grams. You have to monitor the vitamin C doses. You have to see the BSL level when you give it. But it had wonderful results along with IV ozonated saline. The patient was back to his work. He lived for almost 8-9 months, but his death was very peaceful. He could work during that time. So that is also rewarding in case of malignancy. Then pharmacotherapy in pain. For neuropathic pain, you have to follow the new PSIG guidelines. There are neuropathic drugs which are to be given accordingly following the guidelines. Then for cancer pain, you have to follow the WHO ladder. This is my operation theatre. This is the radio frequency machine I am using. This is the PRP machine I am using. This is the C-arm in my operation theatre. It is a 9-inch C-arm and it is enough for giving blocks. Then this is my operation theatre overall, and this is my physiotherapy in my hospital. So these all instruments are more than enough for pain practice. And you know, in metros, the cost of these interventions is very different than our rural areas. Rural areas, actually the techniques or the procedures, the people can afford. So I think that most of the doctors from Satara, from Kolhapur, from Karad, they should enter into pain practice. The orthopedicians, anesthesiologists, if they enter, then it would be even more affordable for the common public. And even the orthopedicians now, considering my slides, the simple techniques, or the anesthesiologist, they can start their giving blocks now also. So with that motto, actually I simplified my lecture. At the end, again, I would like to state one point here. The beauty of pain management is that no surgery is required, and even lengthy hospital stay is totally avoided. Just 4 hours or 2 hours of hospital is more than enough. So this is very, surprising for the patients, and they are very happy with it. I hope by now you all understood what pain management is. And I'm really thankful to Dr. Vaishali Chavan, Dr. Shashi Patil, and all the organizers of ISA and IMA Satara for giving me this opportunity. Thank you. Thank you once again for giving me this opportunity.
I thank Dr. Jadhav madam for giving such an informative lecture regarding pain management. Now I will introduce next speaker, Dr. Vinayak Patil from Sangli. Slide please. Dr. Vinayak Patil sir is consulting anesthesiologist working in Sangli Miraj area. He will deliver his talk on labor analgesia. It will be a recorded lecture.
Good evening, everybody. First of all, I am very much thankful to IMA Satara President, Secretary, and all my all executive members and all my anesthesia colleagues for giving me opportunity to present this topic. Now, childbirth is most painful experiences women will experience in their lifetime, and childbirth pain was divine retribution for Eve's disobedience in the Garden of Eden. So many believed it was wrong to treat the pain and escape God's punishment. Consider the McGill questionnaire pain score. There is no pain at 0 and severe pain at 50. Then the pain of a pregnant woman score is around 30. So you must imagine the severity of pain. Now in the history, in 1847, Dr. J.Y. Simpson first administered ether for painless labor in a woman with deformed pelvis. While in 1853, John Snow has first administered chloroform for painless labor to Queen Victoria. Analgesia for labor and delivery is always controversial. Birth is a natural process and a woman should suffer. These are the thinkings. So for providing labor analgesia, there are concerns for mother safety, concerns for baby safety, and concerns for effect on labor. According to American Society of Anesthesiologists and American College of Obstetrics and Gynecologists, there is no other circumstances where it is considered acceptable for a person to experience severe pain amenable to safe intervention while under physician care. So maternal request is sufficient medical indication for pain relief during labor. Now in this diagram, there are deleterious effects of pain on baby and mother is shown. Because of pain, there is a loss of morale, anxiety. This will lead to sympathetic stimulation, and because of sympathetic stimulation, there is a hyperventilation leading to increased oxygen consumption and hypocarbia. This will lead to reduced uteroplacental blood flow, leading to fetal asphyxia and acidosis. Similarly, because of sympathetic stimulation in mother, there is increased blood pressure, cardiac output, there is delayed gastric emptying time, and there is increase in lactic acid and fatty acid, which will lead to maternal metabolic acidosis, leading to fetal acidosis and asphyxia. So by providing labor analgesia, all these deleterious effects are prevented, and which is beneficial to the mother and baby. Less than 10% of laboring women in US in 2001 underwent childbirth without analgesia. So neuraxial analgesia is by far the most common form of pain management. So there is development of increasingly safe techniques for neuraxial analgesia. These are the pain pathways in labor and delivery. This diagram shows the labor pain at different stages of labor. As the cervical dilatation is initially less during first stage of labor, there is a less pain. But as the labor progresses and the cervical dilatation increases, there is an increase in pain. The pain in the first stage of labor arises from uterine contraction and cervical dilatation and is referred to T10 to L1 dermatomes. While pain in the second stage of labor is caused by distension of the perineum by the presenting part and stretching over the bladder, urethra, rectum and is carried by the lower lumbar and sacral segments. So there are various non-pharmacological methods like acupuncture, massage, hypnosis and other methods like Lamez method, Levio's technique, transcutaneous nerve stimulation, hydrotherapy, presence of a support person, intradermal water injections and biofeedback. In transcutaneous nerve stimulation, the electric impulses are applied to the skin via electrodes, and these in the first stage these electrodes are applied at the level of T10 T11 on either side of the spinous process, and in the second stage these are applied at the level of S2 to S4 on either side of the spinous process. So ideal labor analgesic should provide good pain relief. There should not be any autonomic block, avoiding hypotension. There should not be any adverse effects on the mother and neonate and no motor block. So it should not produce any effect on the labor and delivery, like there should not be any increase in cesarean section rate or forceps or vacuum delivery. Patient should ambulate and it must be economical. So how to achieve these goals? By prenatal education classes, anesthesiologists must become effective educators as well as healthcare providers. Patients should have realistic expectations regarding the pain of labor and variability of individual labor patterns. So, well-informed patients are more likely to accept interventions that may become necessary during labor. So, anesthesiologists should encourage and facilitate the honest discussion of the risks and benefits of the analgesic anesthetic techniques available. So, there are various parenteral agents we are using for painless labor. All these parenteral opiates crosses placenta, and degree of depression of the neonate depends upon the specific agent, dose, time between the administration and delivery, and prematurity. So these are the various systemic analgesics which we are using for pain relief, like pethidine, intravenous ketamine, fentanyl, tramadol, butorphanol and remifentanil. Of these, fentanyl is highly lipid soluble synthetic opioid with analgesic potency 100 times that of morphine and 800 times that of pethidine. It is a rapid onset of action on IV administration within 2 to 3 minutes and short duration of action with no major metabolite makes it superior for labor anesthesia. While remifentanil is recently available in some centers in India, and it is ultra short acting synthetic potent opioid. It has rapid onset and short duration of action, and it is suitable for labor patient control anesthesia. It is useful especially when neuraxial analgesia is contraindicated. So there are various inhalation anesthetics can be used for painless labor. These were the first treatments for labor anesthesia used in modern times. However, as a volatile anesthetics became more commonly used in childbirth, side effects were more commonly encountered like neonatal depression and maternal gastric aspiration. So delivery was completed by aspiration of gastric contents in 66 women of 44,000 deliveries between 32 to 45. So preventing measures recommended by medicine like restricted intake, provision of non-particular antacids and improvement of anesthetic induction techniques. So volatile anesthetics are no longer used for labor anesthesia. However, nitrous oxide is most commonly used worldwide and is welcomed by many participants as a less invasive approach to pain relief in labor, and it's called Antonox. It is the 50% percentage ratio of nitrous oxide with oxygen. The Civox is sevoflurane, which is inhaled anesthetic. This can be used for painless labor in the 0.8% concentration with oxygen, and it requires special equipment, and there are concerns for environmental pollution and maternal amnesia. So larger studies are required to assess the incidence of maternal compromise. So neuraxial analgesia, it is the most reliable and effective method of reducing pain during labor. However, it is encumbered by small but real and predictable risks. So indications for neuraxial analgesia are maternal request, high risk participant especially associated with hypertension, pulmonary or cardiac disease, and fetal complications like prematurity or small for dead babies. The contraindications are patient's refusal, local infection, bleeding disorders. Neuraxial analgesia. Current ASA guidelines note that maternal request for labor pain relief is sufficient justification for intervention, and the decision should not depend on the arbitrary cervical dilatation. So analgesia usually initiated when patient is in active phase of labor with cervical dilatation of 3 to 4 centimeter. Pre-anesthesia checkup should be done and fetal status assessed, and all drugs and equipments of resuscitation should be kept ready. So epidural analgesia is usually initiated by placing the epidural catheter at the level of L2, L3 or L3, L4. So during epidural analgesia, one must give IV fluids, monitor the blood pressure, oxygen saturation, pulse rate, cardiotocograph, as well as position of the patient must be considered. So tests for inadvertent intravascular and intrathecal placement of the catheter is given, and various local anesthetics most commonly used are bupivacaine, ropivacaine, and various adjuvants. Now drugs which are most commonly used are bupivacaine 0.125% 10 to 20 ml plus 2 microgram fentanyl per ml. Ropivacaine 0.125% to 0.175%, which is less cardiotoxic, and the subsequent doses depending upon can be given intermittently by manual boluses or by continuous infusion or by patient control analgesia pumps. 0.125% bupivacaine with fentanyl 5 to 6 ml per hour, these are the usually maintenance doses, and continuous infusion 8 to 15 ml per hour or 0.0625% to 0.125% bupivacaine with 25 microgram of fentanyl can be started after the initial dose. So very dilute local anesthetic mixtures of 0.0625% generally do not produce motor blockade, and many allow some patients to ambulate. These are called walking epidural. So aim is to produce selective sensory block from T10 to L1 with no motor block with addition of opioid in low dose local anesthetic. So long duration of action of bupivacaine makes it more popular agent for labor. Ropivacaine is preferable because of its less cardiotoxic action. If patient control epidural analgesia, here the total drug requirement may be less and patient satisfaction is greater. So patient control epidural analgesia compared with other epidural techniques. These are various settings like 5 ml bolus dose with 5 to 10 ml lockout and 0 to 12 ml per hour basal rate, and 1 hour limit of 15 to 20 ml may be used. So this patient control epidural analgesia allows participant to control the dose of local anesthetic according to severity of pain, and hence improving maternal satisfaction with psychological advantage of being in control of her own therapy. This patient control epidural analgesia various advantages are: there is a reduction in clinician intervention, there is a reduction in amount of local anesthetic and opioid requirement, and there is a less incidence of motor block as compared with continuous epidural infusion. While disadvantages are it requires dedicated infusion pump, and there must be a proper education of the participant in its use. So maintenance of epidural infusion, there are programmed intermittent epidural boluses or automated mandatory epidural boluses are available. Here their preset volume of epidural mixture is administered as a bolus at a time interval by drug delivery pump, and it is superior mode of maintenance of epidural analgesia compared with conventional continuous epidural infusion. While computer integrated patient control epidural analgesia, it is advanced and novel epidural analgesia delivery system with preset algorithm which is programmed to analyze the dose of local anesthetic and to increase or decrease basal infusion rate based on previous hour demand requirement. So combined spinal epidural analgesia can be used, especially beneficial if analgesic request is made in later stages of labor when cervical dilatation is more than 4 to 5 centimeter. So this is advantageous in rapid pain relief for within 2 to 3 minutes. Here intrathecal bupivacaine of 2.5 mg with 25 microgram fentanyl is most commonly used, and walking epidural was first coined to describe low dose combined spinal epidural opioid analgesia because motor function was not impaired and ambulation of the participant was maintained. Single shot spinal analgesia can be given for painless labor. It is one of the easiest technique with success rate of 98% in participant with severe restlessness due to pain during later stages of labor, especially in resource limited situations. Here fentanyl 25 microgram, that is 0.5 ml, with bupivacaine 2.5 mg, that is 0.5 ml. So total solution of 1 ml intrathecally can provide ambulatory anesthesia for 4 hours. Nowadays, anesthesiologists are using ultrasound for imaging of the neuraxial anatomy. It is useful for identification of the epidural space and predict the difficult spine score in obese and difficult lumbosacral anatomy. So, epidural failure rate can be minimized in patients with difficult back. So, there are various complications which can occur like hypotension, unintentional intravascular injection, unintentional intrathecal injection, postdural puncture headache, epidural abscess hematoma and neurological deficit, which are very rare, and all these complications are avoidable or immediately we can treat it. So, newer insights into the myths and controversies. It has been found that backache, patients are considering that epidural anesthesia will lead to backache, but however, in scientific data, there is no increase. It has been found that there is no increased incidence of backache after epidural anesthesia. Similarly, rate of cervical dilatation. Epidural anesthesia, if given early in labor, does not slow the progress of labor, but many think that it will prolong the labor. Prolongation of second stage of labor. It is possible by 1 hour due to relaxation of pelvic muscles, which may delay the fetal descent or rotation. Incidence of instrumental delivery is more. However, the incidence of cesarean section has not increased. Urinary retention can occur due to opioids, which can be treated with catheterization. According to one survey-based study by Awareness Knowledge Attitude about labor anesthesia among providers and parturants, this study has been done by Rani Ponnuswamy, Hemant Reddy and Ravi Shankar. So there are various, in this study, they have mentioned what are the barriers for anesthesiologists, for obstetrician and for antenatal mothers for using painless labor, epidural anesthesia for painless labor. For anesthesiologists, there is a barrier to widespread practice, concerns about increased chance of instrumental delivery. They need to spend more time, need for continual monitoring and low financial benefits. But for obstetrician, what are the barriers for using painless labor commonly? These were the non-availability of anesthesiologists for epidural anesthesia. They need to spend more time and need for continual monitoring, and majority of them preferred parenteral analgesics for pain relief. Similarly, antenatal mothers preferred painless labor by means of parenteral mode because of their concerns about safety of epidural technique for their neonate, chances of cesarean delivery, backache and extra cost. So, healthcare education regarding benefits of labor anesthesia and setting up the delivery suites for delivering standard of care will increase the acceptance by parturants and the practice of epidural anesthesia by healthcare professionals. So, to conclude, individualized technique to patient's goal and stage of labor, optimize management for spontaneous delivery and provide safe, cost-effective analgesia. Thank you very much for quiet listening.
Thank you, Dr. Vinayak Patil, for giving an elaborate lecture on labor anesthesia. If any questions from the audience, they are welcome. I think we should, this is the last lecture.
Yes, sir.
So today's session is over now.
I request.
I hand over to the organizers now.
Okay.
Thank you.
Thank you, Gosai sir. Thank you, Dr. Parimal. I request Dr. Vaishali More madam to felicitate Dr. Gosavi sir as chairperson. I request Dr. Chaitali Jathar madam to felicitate Dr. Parimal sir as chairperson. Thank you, SATCON. IMA Satara, President Dr. Sharad Jagtap sir, and all the members of SATCON for giving this opportunity to present a whole day workshop to the ISA Satara. Best of luck for tomorrow's and day after tomorrow's session for IMA, and have a wonderful SATCON 24. Thank you.
Thank you, ISA Satara, and thank you all the delegates for patiently attending the conference, enjoying the feast of such a fantastic workshop conducted by ISA Satara today. And everyone enjoyed the academic feast that was delivered by anesthesia team of Satara. Such an excellent day today it was. So thank you all the delegates, and be geared up for the tomorrow session. Tomorrow there will be more exciting lectures coming up, and thank you. Good night. Thank you. We'll start tomorrow at 2 p.m. sharp.